everyone, and welcome to the final day of ACE Kolkata. Let's get on with the first session of the day, and that is a series of 3 papers, part 2 clinical. It's my honor to introduce our chairpersons for this session, Dr. Shakti Rupa Chakrabarti and Dr. Shobhandev Kalpahar. Dr. Shakti Rupa Chakrabarti is the chairperson of Public Awareness Committee. She is the managing committee member of BOG, member of different professional bodies like IMS, Endometriosis Society of India, ISAD, etc. And she's actively involved in CNEs, etc. She's contributed chapters in several books and has participated in several national and international conferences as faculty as well as a speaker. Welcome, ma'am. Dr. Shobhandev Kalpahar is Dr. Shobhandev Kalpahar is a consultant at Institute of Reproductive Medicine, Salt Lake, and has contributed several chapters in different infertility books and has presented in different national and international conferences. Welcome, sir. And over to you both.
A very good morning. Am I audible?
Yes, ma'am.
Okay. I welcome all the speakers, all the dignitaries and everyone at this very prestigious platform of ACE. Now, please give me the CV of the first speaker. Yes.
Ma'am, I think you can move on without the CV and just.
No, I want to know the speakers list.
Should I help you out with that?
Okay. So, who's the speaker? Rashid. Yes, may I call Dr. Dakshanya Pridhipan, and he is going to speak on impact of. She is going to speak on impact of prepubertal hyperglycemia on ovarian reserve and functional competence of oocytes. The stage is yours, Dr. Dakshanya.
Thank you, ma'am. Ma'am, are my slides visible?
Yes.
Yeah. Okay, shall I go ahead, ma'am?
Yes, please go ahead.
Okay, thank you, ma'am. Good morning, everyone. I'm Dakshanya Pratibhan here to present our research work on the impact of prepubertal hyperglycemia on oocyte functional competence during the reproductive period, carried out at the Department of Reproductive Science, Kasturba Medical College, Manipal. The spectrum of reproductive dysfunction is broad, but in the recent days, there is a sharp rise in the global prevalence of diabetes. Moreover, studies have revealed that women with hyperglycemia have increased follicular apoptosis, abnormal folliculogenesis, poor polycystic ovarian morphology, and increased ovarian androgen production. Furthermore, to understand the impact of hyperglycemia on ovarian reserve and oocyte functional competence, several studies had been performed using animal model. These studies revealed that hyperglycemia often leads to abnormal ovarian function by lowering the hormone levels and angiogenesis. It also leads to DNA damage by impairing the DNA repair mechanisms and apoptosis. Further, it also leads to reproductive dysfunction by lowering the fertilization rates and embryo development. However, it is still unknown if hyperglycemia from the prepubertal years have shown any influence or impact on affecting the oocyte quality and functionality during the reproductive phase of life. Hence, we were interested to know if prepubertal hyperglycemia will have impact on the functional competence of oocytes during the reproductive period. Therefore, we hypothesize that hyperglycemia from the prepubertal years will lead to reproductive dysfunction during the reproductive phase of life. To address this, we used an experimental model to mimic the effects of hyperglycemia in prepubertal life and to further assess the oocyte functional competence during the reproductive phase of life. Streptozotocin is a widely used chemical compound for the induction of experimental diabetes. Hence, healthy female mice of 3 weeks old was administered a 3 successive dose of 75 mg per kg body weight, and the vehicle control received equal volume of sodium citrate buffer. The control group did not receive any injections. The animals were sacrificed after 3 months of maintenance period. And during the 3 months of maintenance period, they were regularly checked for blood glucose and change in body weight. After sacrificing the animals, the ovaries and oocytes were obtained. Ovarian reserve is the predominant element to determine a female's reproductive lifespan. Hence, the ovaries were enzymatically digested to perform the follicle count, and the ovaries were also subjected to histological analysis. Furthermore, to understand the oocyte functional competence, the GV oocytes devoid of cumulus were subjected to in vitro maturation to further understand the maturation potential, mitochondrial potential, and genetic inductivity of the M2 oocytes. The random blood glucose level was checked once in 3 days, and it was observed that there was significant increase in the blood glucose levels from day 3 till day 21 post-injections. This showed that the hyperglycemic condition was successfully established. So we further started with assessing the ovarian weight, where we found that the ovarian weight was significantly reduced in the prepubertal hyperglycemic condition when compared to the control and vehicle control groups. Hence, we were interested to look into the effect of prepubertal hyperglycemia on the ovarian reserve, and we assessed the total number of follicles in the ovary. We observed that the total follicle count comparatively decreased. However, we couldn't achieve any statistical significance here. And the images present here represent the histological sections of the ovarian tissue stained with hematoxylin and eosin. These results indicated that the ovarian reserve is retained in the prepubertal hyperglycemic model. Since the ovarian reserve was not evidently compromised, we were further interested to know about the oocyte maturation potential. So we subjected the GV oocytes for in vitro maturation, where we observed that the maturation potential of the prepubertal hyperglycemic model was significantly compromised when compared to the control groups. Having known that oocyte maturation is compromised in the hyperglycemic condition, it is important to understand the functional competence of the matured oocytes. We all know that the regulation of mitochondrial dynamics is important for oocyte maturation. And so, we stained the matured oocytes with JC1, a dye that is commonly used to indicate the mitochondrial membrane potential. This dye exhibits red fluorescence in the presence of active mitochondria and green fluorescence in the presence of inactive mitochondria. We noticed that the mitochondrial membrane potential was significantly reduced in the oocytes exposed to prepubertal hyperglycemic condition when compared to the control groups. This showed that a prepubertal hyperglycemic condition has negative influence on the oocyte functional competence. Moreover, the integrity of the meiotic spindle in M2 oocytes is crucial for normal fertilization and as well as for further development. So we looked into the spindle morphology, and here we observed that there was 2.25-fold increase in spindle abnormality in the oocytes exposed to prepubertal hyperglycemic condition. To summarize, this study revealed that though prepubertal hyperglycemia doesn't compromise the ovarian reserve during the reproductive phase of life, it significantly alters the maturation potential, mitochondrial potential, and spindle integrity. This shows that prepubertal hyperglycemia can have adverse effects on the oocyte functional competence during the reproductive phase of life. Also, further studies are being done to address the embryo quality and implantation potential of embryos derived from the prepubertal hyperglycemic condition. This is the first, I would like to enhance the strength of the study. This is the first experimental study elucidating the impact of prepubertal hyperglycemia on the oocyte functional competence during the reproductive phase of life. Moreover, the major strength of our study is that we have carried out in vitro maturation at 5% oxygen tension. That is, it is physiological oxygen concentration. This was done in order to mimic the clinical scenario. However, we have one limitation, that is the outcome of this study cannot be directly correlated to clinical scenario since the patients will be advised for medications which might alter the consequences. I would like to acknowledge my guides, Professor Satish Kumar Adiga, Professor Guru Prasad Kaltur, Dr. Subhashri Upengala, from the Department of Reproductive Science, Kasturba Medical College, Manipal Academy of Higher Education, Manipal, and Professor Borut Kovacic from University Medical Center, Maribor. I also extend my gratitude to SERB India for their financial assistance. Last but not the least, I would like to acknowledge ACE 2021 for giving me an opportunity to present in this conference. Thank you.
Thank you. It was excellent presentation and your work was very good.
Thank you, ma'am.
Okay. Now the questions, if we find will be later. Or I'll ask you one question. How do you explain the activities of follicles due to hyperglycemia?
Activity of follicles, yes, ma'am. So there are few papers that have shown diminished ovarian reserve due to hyperglycemia.
How do you explain it? Why?
I couldn't get the question. How do you explain, like, okay, how I've performed the experiment, is it?
No, I mean the physiopathology. Why does it occur?
I mean, here with respect to the prepubertal hyperglycemia, here we couldn't achieve any, there was no difference in the follicle count, ma'am. So we feel that the folliculogenesis isn't affected during the prepubertal hyperglycemic condition and when it is assessed during the reproductive phase.
Okay. Okay, now thank you. I now shift over to my person.
Ma'am, one question.
Yes.
Nice work. Can you tell me how you have checked the spindle integrity in your paper?
Yes, sir. Yes, sir. So actually, this was a immunofluorescence assay. So this was assessed during immunofluorescence, and we used the gene alpha tubulin marker.
You have told that the ovarian reserve and embryo potential in the later period you will check. But can you say the ovarian response regarding in their reproductive age group, what might be the ovarian response in these type of patients?
Sorry, ovarian, that is what. So actually ovarian response, we thought with respect to hyperglycemia, there are studies that hyperglycemic, I mean, the ovarian reserve has been diminished. But with respect to prepubertal hyperglycemia and assessment during the reproductive phase, it was surprising that there is no effect on the ovarian reserve as such. However, there is a difference in the maturation rate. That is, there is diminished maturation rate. And
no, I am not asking the
yeah.
reserve. I am
Okay.
asking the response, which is more important in during our reproductive phase,
Yeah.
during our ERT procedure, IVF stimulation. We have seen in diabetic women undergoing the IVF, the response is poor.
Okay, fine, I got it. So response in the sense the number of oocytes retrieved, like that you're asking, is it?
Yeah.
Okay, so I couldn't find, as such, we couldn't find any major difference in that, sir. There is abnormalities, but in the response, the number of oocytes retrieved, there is no much difference.
Okay, thank you.
Yes.
Okay. I now shift over to my co-chairperson, Dr. Shobhandev. Please call the next person.
Okay. Thank you so much, ma'am.
Please. Thank you.
Next speaker, Kothai Natticher Anbad Jagan. She is from ERC International Fertility and Research Center, Tamil Nadu. Your time starts now.
Hello, sir. Can you hear me?
Yeah, you're audible.
Good morning, sir. Good morning, ma'am. First, I would like to extend my hearty congratulations to ACE 2021 for having this wonderful conference entirely on a virtual platform. I will first share my screen. Is my screen visible, sir? Hello?
Yes, ma'am.
Yes, it's visible.
Okay, ma'am. So my topic today is about endometrial receptivity array, or ERA, and we have done a little study to find out whether endometrial receptivity array is necessary for identifying the non-receptive endometrium rather than the receptive endometrium, and how can we improve the success rate with the personalized embryo transfer. A little bit of background before going into the study proper. As we all know, implantation involves a complex and an intricate dialogue between the endometrium and the embryo. For any successful pregnancy, we need three important components. One is a competent and a viable embryo. Second one is a receptive endometrium. And third and most important is a synchrony between the two. So, as we all know, the post-ovulatory endometrium, due to the effect of progesterone, becomes receptive, permitting the implantation of the embryo. Usually, it occurs on day 19 or 20 of the cycle and remain open for a very few days. This is the implantation. This is called the window of implantation. In a natural cycle, this usually occurs on LH plus 6 to LH plus 9 days. While in a hormone replacement cycle, that is in a HRT cycle, it occurs on P plus 4, that's progesterone plus 4 to progesterone P plus 7 days. So there are a lot of new studies which suggest that this window of implantation is temporal and spatially restricted. That is, as assumed earlier, it was not a fixed window for all patients, but it may be displaced or shortened in patients, especially those with repeated IVF failure. And this is another study by Encesco et al. And they found they tried to find the receptivity of the endometrium after progesterone administration. And in this study, they found that 20% of the patients have a receptive endometrium just with 2.5 days of a progesterone administration, while for another 20%, the receptivity will be achieved only after 8 long days of progesterone administration. The study found that most patients become receptive to progesterone after 5 to 6 days of progesterone administration. So coming to endometrial receptivity array and how does it plays a role in identifying this endometrial receptivity. This technology involves DNA microarray, where multiple or thousands of genes are analyzed simultaneously. During the post-ovulation, in addition to the secretory changes in the endometrium, there will be a transcriptional awakening of genes, and endometrial ERA tries to identify this awakening by analyzing about 283 genes and try to establish a transcriptomic signature of the endometrium. One important point about this ERA test is it's highly sensitive, it's specific, and it's also highly reproducible. So coming to my study proper, my study tried to compare the clinical pregnancy rate in patients who underwent ERA with those who did not prior to embryo transfer, especially in those patients with previous IVF failure. Also, the receptivity and non-receptivity status of the patient prior to embryo transfer was compared for clinical pregnancy rate. This is a multi-center retrospective observational study done from March to July of 2021. A total of 140 patients with previous failed IVF cycle were included. Age group of the patient included in the study falls from 22 to 50 years with a mean age group at 35 years. ERA was done for a total of 70 patients and the receptivity of the endometrium was identified, and a statistical analysis was done using Fisher's exact test. Patients with the uncorrected uterine or adnexal pathology were excluded from the study. Also, those who had a difficulty in transferring the embryo during previous cycle and a thin endometrium. Also, patients who had a different gamete plan from the previous cycle were excluded from the study. All patients underwent an endometrial biopsy or FET with the HRT protocol. First, estradiol valerate was started from day 2 or 3 of the cycle with an initial dose of 2 mg and increased till an endometrial thickness of 7 mm was achieved. Once a desired thickness of endometrium is achieved, injection sustain 100 mg and vaginal progesterone suppository of 400 mg was given for 5 days. After complete 5-day of administration, on day 6, endometrial biopsy was done with pipal catheter, and the tissue was transferred to a cryotube containing RNA stabilizing agent, since we are going to analyze the RNAs, and it's kept in a refrigerator for 4 degrees Celsius. After 4 hours, the sample was sent to analysis, and the results were available after 2 weeks. So, of the 140 patients who underwent this, included in the study, 70 was underwent ERA and 70 was used as control. For the patients who have a receptive endometrium after ERA, in the next cycle, embryo transfer was done, simulating the ERA cycle, while the non-receptive patient was further divided into a pre-receptive or a post-receptive group, and embryo transfer was planned accordingly. That is, in the pre-receptive group, the transfer was done either on P+6 or P+7 days, while in the post-receptive group, the transfer was done on P+3 or P+4. In some patients, when the window is shortened, the transfer is done on P+5.5 or P+6.5 days as suggested by your geneticist. Of the 70 patients, 35 became positive, and in the non-ERA group, only 30 became positive. The clinical pregnancy rate was 50% for ERA group, and it is 42.8% for those who did not underwent ERA. There is no much statistical significant difference between these two patients, as the p-value was more than 0.05. But when we compared the clinical pregnancy rate between the receptive and the non-receptive endometrium, we found that receptive endometrium was found in 39 patients, out of which 18 patients became pregnant, while in the non-receptive group of 31 patients, 17 became pregnant. The clinical pregnancy rate was 46.1% in the receptive group, while it's 54.8% in the non-receptive group, which is little higher, and there is a statistical significant difference between these two. This state that or suggests that non-receptive endometrium group patients clearly benefited from optimizing the transfer timing based on their receptivity status. So as in the case of ovarian stimulation protocol, endometrial preparation protocol can also be personalized for each patient, as one size fits all approach is a paradigm of the past. At least those patients with a non-receptive endometrium will definitely benefit from such an approach, as studies find that this window of implantation is not fixed. It is it may be significantly displaced or shortened, and also it's not a pathological entity. That is, it's just moves a little bit. So if we adjust that window of implantation and our transfer timing accordingly, they will have a definite improvement in a pregnancy rate and an implantation rate. Also, another benefit of using ERA is that it's highly reproducible. That is, the results found from ERA are found to be consistent even after 1 to 2 years. So the test need not be carried out repeatedly. Also, recent studies suggest that a lot of women with uterine pathologies like adenomyosis or endometriosis also found to have a displaced endometrial receptivity. So these patients will definitely benefit from such an approach. So transferring a euploid embryo coupled with this ERA will definitely improve clinical outcome and maybe a next step forward. So coming to the conclusion, my study concludes that optimizing the timing of embryo transfer, especially in non-receptive group, will improve the clinical pregnancy rate. Thank you. Hello.
It's a nice presentation.
Yes, sir.
Um, can you say what are the limitations of the ERA test?
Limitation of ERA test, sir.
Yeah.
What shall we say? Our study found that I don't know. But this is a retrospective study. That is our study's limitation. But I don't know much about what is the limitation of an ERA.
It is costly, it is invasive, and you can also you cannot perform it during the transfer cycle, and you cannot assess the endometrium embryo crosstalk. It is also important. Do you think the NGS is better than the ERA technique nowadays?
I'm sorry, sir. What is it?
Do you think NGS next generation
Yeah,
sequence
yes, sir.
nowadays?
That is definitely improving the success rate, because like a previous era, we use a microarray technology where only very few genes are studied. But with the this next gen sequencing, it will definitely improve, because a lot number of genes are studied in this thing, and these found that the results are more consistent with the NGS than previously.
Okay, thank you.
Thank you.
I think we are already going over time. So our next speaker is Dr. Surya Mali. It is my pleasure to call you on the stage, and your time starts now. Dr. Surya Mali, and you are going to speak on single versus multiple dose of GnRH agonist as luteal phase support. Please take your seat, please. In frozen artificial cycles, a pilot study.
Hello, am I audible, madam?
Yes, you are audible.
Okay.
Please
Thank you.
continue.
Yeah. Good morning, everyone, and respected sir and ma'am. I am Dr. Surya from Kraft Hospital. I am here to present a study on single versus multiple dose of GnRH agonist as a luteal phase support in frozen artificial cycles, a pilot study. First of all, I am really grateful to ACE 2021 for giving this wonderful opportunity to present my piece of work in this prestigious conference. So let's start. Introduction. Luteal phase deficiency is a common feature of the cycles resulting from stimulation of follicular development. It has been reported in cycles down-regulated with the GnRH agonist and stimulated with human menopausal gonadotropin or FSH, and cycles during which an antagonist is used in combination with human menopausal gonadotropin and FSH. Hormonal value during implantation is very crucial to embryo-endometrium interaction and to the viability of the conceptus. Alterations in the peri-implantation environment following the superovulation are considered to impair the perinatal outcomes in vitro fertilization and ICSI compared to the FET cycles. Along with improvements in cryopreservation techniques and resulting increase in success rates, a freeze-or policy has been suggested. Various cycle regimes for frozen thawed embryo transfer have been in use since long time, but according to the Cochrane review, there is insufficient evidence to support the use of one cycle regimen in preference to the other in preparation for FET. In hormonally substituted artificial cycle for FET, administration of estrogen and progesterone is necessary to induce the endometrial receptivity and to maintain the ongoing pregnancy due to the lack of corpus luteum and endogenous sex steroid production. These cycles are dependent on extrinsic luteal support, which can be in the form of progesterone or HCG. The introduction of antagonists in the common clinical practice of IVF cycle has raised several new concepts, both for the trigger to be used and for the attention to the luteal phase. Tesserick et al. Have shown for the first time that the luteal phase GnRH agonist administration enhances the clinical outcomes of the GnRH agonist and antagonist treated ovarian stimulation cycle. This was the study done by them in 2006, which had clearly depicted the beneficial role of agonist as a luteal phase support in both agonist and antagonist cycles. Now, the presumed beneficial effect of the GnRH agonist. First, on the corpus luteum. GnRH stimulates secretion of LH from pituitary. This may maintain the corpus luteum function. Now, on the endometrium. GnRH receptors are also expressed in both the stroma and the epithelial cells of the endometrium, particularly with the highest level in the luteal phase. Endometrial GnRH receptors modulate several paracrine factors such as the transforming growth factor, fibronectin, matrix metalloproteinase, and N-selectin, which have important roles in the implantation process of the embryo. Now, in the embryo, also GnRH receptors are expressed. Pre-implantation mouse embryos express GnRH receptor mRNA, and their in vitro development is significantly enhanced by incubation with increasing concentration of GnRH agonist and increased or completely inhibited by incubation with increasing concentrations of antagonist. GnRH seem to have the direct effect on the embryo by firstly a primary regulator of HCG synthesis that is evaluated both in vivo and in vitro, and secretion in both pre-implantation embryos and in the placenta, and secondly successful rates of implantation and delivery of the live birth. These two mechanisms are particularly responsible to beneficial effect on the frozen embryo transfer cycles. Now, meta-analysis by LTM et al. Found an increase of the pregnancy rate of 22% by adding agonist in luteal phase with no evidence of heterogeneity. These are the cycles which he took in consideration, frozen cycles, and we will discuss in detail. We therefore postulated regarding the enhanced effect of agonist as a luteal phase support by administering 3 doses subsequently in alternate days. Hence, a pilot prospective study was done to check this methodology. Patients are recruited for this single center pilot prospective study from January 2021 to March 2021 according to the inclusion and the exclusion criteria. Total 70 patients were recruited for this pilot project. Written informed consent was taken from each patient after explaining the sort of intervention. Patients were divided into 2 categories: a study group which comprised of 34 patients, 1 patient's FET got cancelled due to unavoidable reason, and the control group which comprised of 35 patients. Now, the inclusion criteria was age should be less than 40 years, at least 1 good quality embryo should be there for transfer, artificial or HRT cycle are only preferred, first and second FET attempts. Exclusion criteria was endometriosis stage 3 and 4, non-obstructive azoospermia, BMI less than 18 or more than 30, ET less than 8 on the day of the transfer, poor ovarian reserve according to the Bologna criteria, and uterine pathology which may affect the implantation such as the submucous fibroid, intramural fibroid, polyp and adhesions. Not able to move my slide. What has happened? Madam, I'm not able to move my slide. There is some problem, I guess. Yeah, okay. In both the patient, controlled ovarian stimulation was done by flexible antagonist protocol. Embryo transfer was planned 2 months later after cause. Now, in both the group of the patient, endometrial preparation was done using the HRT cycle. It started with administration of oral estradiol tablet, estrabet 2 mg 3 times a day, which was titrated according to endometrial assessment by ultrasound. Once the endometrium reached 9 mm, micronized progesterone in the form of tablet 400 microgram twice a day vaginally was started. Now the study group. In the case of cleavage and blast transfers, injection triptolane acetate 0.1 milligram subcutaneous. First dose was given on the day of the transfer, and second and third dose was given subsequently on the alternate days. That is total of 3 doses. At versus in the control group, patients were given only 1 dose of the decapeptyl 0.1 milligram on the day of the transfer, both day 3 and day 5 transfer. That is only 1 dose regimen was there. Now we see other primary outcomes. Primary outcome for the ongoing pregnancy rate defined as when the pregnancy had completed more than 20 weeks of the gestation. The intermediate outcomes were clinical pregnancy rate. Clinical pregnancy rate was calculated by the presence of intrauterine GSAC at 5 to 6 weeks after ET on ultrasonography divided by the total number of patients who underwent the embryo transfer. Implantation rate was defined as total number of GSAC divided by the total number of embryos transferred. Miscarriage rate were defined as number of clinical pregnancy losses before 20th week of gestation divided by the total number of the clinical pregnancies. And biochemical pregnancies were defined as a positive beta CG, where positive was more than 40 international units. That was not followed by a clinical pregnancy. Now the results. Both the study group and the control group comprised of 69 cycle in total. No significant difference was noted in the demographic profile of the patient in both groups, including the age, type of infertility, previous ICSI attempts. Regarding the embryology parameter, fertilization and cleavage rate were similar in both the groups. Number of good quality embryos were quite comparable in both the groups. This is a demographic profile and the embryology parameters, which are almost comparable in both the groups, study as well as the control group. Now we see on the results, the outcomes. Primary outcome, that is the ongoing pregnancy rate, is similar in both the groups. We can very well see here it is 41.2 versus 42.9. That is hardly a difference is there. Intermediate outcomes, including implantation rate, were also comparable in both the groups. Clinical pregnancy rates were slightly better in the study group, but the difference was not significant. So now let's see what the evidence says. Is it useful or useless to use the agonist as a luteal phase support? This was a review done by Cochrane luteal phase support for assisted reproductive cycle in 2015. Cochrane review regarding luteal phase support included 10 RCTs and 2,861 patients demonstrated the beneficial effect of addition of agonist during the peri-implantation period on ongoing pregnancy rates and live birth rates compared with the progesterone alone for the support. Multiple dose regimen studies, including Cochrane review, maximally focused on fresh transfer and GnRH long down regulation protocol during controlled ovarian stimulation. These are the studies which have been incorporated in the Cochrane review, and all these studies have been done on the fresh transfer. There is no study on the frozen transfer and multiple dose regimen. That's why we plan to do this study, this pilot project. Now see what the other researchers say. Davar et al. In 2015 did a randomized control trial investigating the agonist single dose regimen to luteal phase support in frozen thawed embryos transfer cycle. The author randomized 200 patients into two groups, 100 each, to whom a single dose of 0.1 milligram was given 3 days after ET, and group 2 in which it was not administered. No significant difference was found in the clinical and the ongoing pregnancy rates. Next was Shikla et al. In 2018 recorded in their prospective interventional pilot study, that is the number was 101, an observable but insignificant difference in the LBR and miscarriage rate favoring the luteal phase agonist support. Single dose of 1.1 milligram of triptolane when the age of transferred embryo reached the 6 days was administered in his studies. Now, Ye et al. In 2019, in their prospective randomized control trial, which comprised of 787 patients, quite a good number, showed no significant benefit on the pregnancy outcomes when the administration of single dose of GnRH agonist, that is 0.1 milligram 3 days after ET in the artificial frozen embryo transfer cycle was done, which is quite comparable to our observations, except the doses regimen. Now the strength and the weakness. Our studies regarding the multiple dose regimen of decapeptyl as luteal phase support in the FET cycle. In the literature, as we saw, there is very scarce data regarding the same. Maximally, the studies of multiple doses has been done on the fresh transfers, so hardly there is any data regarding the frozen transfer and multiple dose regimen. Though the sample size is very small due to a pilot study, but it tries to throw the light on the outcomes. More further randomized control trials are needed to evaluate this regimen on a bigger cohort of the patients. To conclude, multiple dose regimen of using agonist decapeptyl failed to show any concretely beneficial outcomes in terms of ongoing pregnancy. Further, vigorous prospective control trials are needed to evaluate regarding the potential benefit of multiple dose regimen in the artificial frozen embryo transfer cycles. These are the references in my studies. Thank you so much.
Yes, thank you, Surya, for your wonderful presentation. And I'm giving the mic to my co-chair, and to proceed with the next, we are we have to keep at par with time. If you want, you can ask one question and
One
carry
question.
it forward.
Ma'am, one question.
Yes.
Nice presentation.
Thank you, sir.
You have told triptorelin 0.1 milligram. I give him both in study. There is 3 dose and 1 dose in control group.
Yes, sir.
Does the difference between these 2 groups becoming less powerful by this means you have also given the 1 dose of triptorelin in control group?
Yes, sir. Yes, sir. We have given 1 dose because we have been regularly practicing this practice of giving 1 dose at the time of embryo transfer. This we have been continuing since past, I think, 2 or 3 years, 4 years. So this was like the regimen was continued, but this one, like addition of the further 2 doses was suggested because we have undergone the further studies that have been done like the previous. So there were hardly any any study done on the FET with the multiple dose regimen. So we tried to plan this pilot project. Is there any beneficial effect so that we can we can apply this to our clinical practice?
Okay, thank you.
Thank you, sir. Thank you so much, sir.
Now the next speaker is Priya Senthil from ERC Fertility Center, Tamil Nadu. Please, your time starts now.
Good morning, sir. Good morning, everyone. I'm Dr. Priya Senthil, consultant in ARC Fertility Center, Coimbatore, Tamil Nadu. My topic for discussions today is about the study comparing the oocyte maturation rate, that is number of metaphase 2 oocytes retrieved in recombinant HCG trigger and triptorelin acetate trigger. Normally, the GnRH, can you change the slides, please? Next slide, please. Normally, the GnRH is secreted from the hypothalamus during follicular phase in a pulsatile manner and discharged into pituitary portal system and bound to its receptors on gonadotrophin cells in anterior pituitary. FSH and LH hormones are released in pulsatile manner, which is needed for follicular growth and ovarian secretion of estrogen. In mid-cycle, high level of estrogen and slightly high progesterone levels cause sudden surge of gonadotrophins, especially LH, which induces ovulation in 36 to 40 hours. Next slide, please. Classically, HCG has been the gold standard for induction of ovulation as a surrogate for the mid-cycle LH surge for several decades. Due to structural and biological similarities, HCG and LH bind to and activate the same receptors, the LH-HCG receptor. However, the half-life of LH is around 60 minutes, whereas the HCG is more than 24 hours. Due to its prolonged half-life and increased glycolization, HCG exerts a sustained luteotropic activity, and it increases vascular permeability by vascular endothelial growth factors, which may cause the occurrence of OHSS. Next slide, please. Whereas GnRH agonists cause LH surge along with FSH surge, similar to natural cycle, which can result in more number of good quality oocytes. After GnRH agonists, the LH surge occurs faster than HCG. It has shorter duration of LH surge, which can prevent and reduce the incidence of OHSS. However, the amount of gonadotrophins released after GnRH agonist trigger are significantly reduced compared to normal cycle. And the gene expression of enzymes involved in steroidogenesis is lesser in GnRH agonist trigger than the HCG trigger. So there is a concern that if it causes adequate LH surge for follicular maturation. Next slide, please. LH surge triggers ovulation after 36 hours. It causes expansion of cumulus oocyte complex, helps in reception of meiosis, luteinization of granulosa cells, and formation of corpus luteum. Next slide, please. FSH surge induces LH receptor formation in luteinizing granulosa cells, promote nuclear maturation of oocytes, and better cumulus expansion. Also, it causes release of proteolytic enzymes involved in the process of ovulation. Next slide, please. So the goal of our study was to compare the number of metaphase 2 oocytes retrieved after controlled ovarian stimulation using fixed recombinant FSH in GnRH antagonist cycles after triggering with recombinant HCG and GnRH agonist triptorelin acetate for final follicular maturation. Next slide, please. It's a prospective randomized study done from May 2019 to October 2019 at ARC Fertility Centers at Coimbatore. 100 subfertile patients who fit into the inclusion criteria were randomly allotted to 2 groups containing 50 each. Next slide, please. Patients from 21 to 35 years of age with BMI 18 to 30, with AFC of 8 to 24, with AMH level ranging from 1.5 to 4 nanogram per deciliter, and serum estradiol level 3001 to 5000 picogram per ml were included in the study. Who don't fit into the criteria were excluded. Next slide, please. After confirming the pituitary downregulation, recombinant FSH was started from day 2 or day 3 according to their BMI, age, AFC, and AMH. And GnRH antagonist was started from day 6 of stimulation to premature LH surge. Growth of the follicles was monitored with serial ultrasound. LH and E2 were checked on stimulation day 6, day 8, and day 10. Next slide, please. Trigger was given when the lead follicle reached 24 mm, so that maximum cohort were between 16 to 22 mm. One group received recombinant HCG of 250 microgram and the other group received triptorelin acetate of 0.2 mg. OCR done at 36 hours after recombinant HCG trigger and 35 hours after triptorelin acetate trigger, and the number of metaphase 2 oocytes retrieved were compared between 2 groups. Next slide, please. Next slide, please. Yeah, our study showed that patients triggered with triptorelin acetate had more number of metaphase 2 oocytes compared to patients treated with recombinant HCG trigger. The groups were analyzed by their age, BMI, AFC, and AMH. The total dose of gonadotropins used for GnRH agonist triptorelin acetate and recombinant HCG group differed. Duration of stimulation was also differed. Everything, lead follicular size, number of follicles more than 10 mm, and number of follicles aspirated, everything was, there was significant difference. Next slide, please. This high yield of M2 after GnRH agonist trigger may be due to the fact that GnRH agonist stimulates FSH surge also along with LH surge, similar to normal cycle. This is similar to many studies which prove GnRH agonist trigger yielded more good quality oocytes. Unlike HCG trigger, FSH surge leads to better oocyte recovery rate and higher fertilization rate. Next slide, please. So in conclusion, both recombinant HCG and GnRH agonist triptorelin acetate are effective for final oocyte maturation, but triptorelin acetate may yield more M2 oocytes compared to recombinant HCG. Nevertheless, more researches are needed to confirm the same. Next slide, please. Acknowledgement. Actually, I would like to thank Dr. Mahalakshmi Saravanan, Dr. Saravanan Lakshmanan, and Dr. Nidhi Sharma for helping me with this study. Thank you. Thank you, everyone.
A nice presentation.
Thank you, sir.
You have told the trigger was given when the lead follicle reached 24 millimeter. Is it your routine practice or it is a little bit late?
No, actually, it is our routine practice. It is our protocol, so that maximum cohort will come into that 16 to 22 mm.
Okay. Can you say what are the limitation of GnRH agonist trigger? Means where we cannot use the GnRH agonist triggers?
GnRH agonist actually in agonist cycles we cannot use GnRH agonist trigger. And
also where you are planning the phase transfer, the luteal phase defect is very commonly associated.
Yes, yes. One of the major impact is luteal phase deficiency. So we have to be very vigilant with proper luteal support. Yes.
And also where there is a hypothalamus pituitary dysfunction or LH level is pre-trigger LH level is less. Otherwise, your presentation was very good. Very nice presentation. Thank you.
Thank you, sir. Thank you very much.
Yes. Thank you, Priya. Now it is the turn of the speaker, Dr. Amsaveni Prakasam. It is my pleasure to call you on the stage just now. Start with your topic, please, right away. Yes, Dr. Amsaveni.
Yeah, hello, ma'am. Hello, everyone. Sorry for the thing. So, myself, Dr. Amsaveni Sivaprakasam. Yeah, Amsaveni Sivaprakasam. I'm a veterinary professional. So, I'm specialized in veterinary microbiology. I'm going to present today my work on PG Advanced Reproductive Biotechnology in Animal Models. I'm going to present that today. Okay, so I thank AS conference people for providing
Sorry
this
to interrupt,
opportunity
ma'am.
to provide a
Make
yes,
it,
yeah,
your slides, make it full screen.
And Dr. Shobhun, I would like to inform you, I'll be moving away to Hall D. You take over when she finishes.
Is it okay, sir, now?
Okay, madam.
Okay,
No, ma'am.
thank you.
It's
Yeah,
still in.
okay. No. Yeah, I'm just presenting the full screen only, sir.
Ma'am, please stop share and reshare again.
Okay. Is it okay now, sir?
No, ma'am. Shall I display your slides?
Yeah, that's okay. Okay, thank you.
Ma'am, please continue.
So yes, yeah. Thank you so much. So today I'm going to speak effect of nicotine on buffalo oocytes and green anacolloid supplementation, which is an animal model. So this is work done as a part of my PG diploma in advanced reproductive biotechnology in animal models. Next slide, please. Okay, so importance of the study is that, so in vitro maturation, it's a process by which the immature oocyte attain the developmental competence. So normally the oocytes, they are the major sources of reactive oxygen species. So the energy is required through the mitochondrial oxidative phosphorylation, but the increased ROS level, which is beyond the normal physiological range, that's going to result in the oxidative stress and leading to the failure of embryonic development. So oocyte protection against this ROS, this plays a major role in pre-implantation during the embryonic development. So the antioxidants, like it could be a non-enzymatic or enzymatic, they are the ROS scavengers, which help to maintain the oocyte's oxidant and antioxidant balance. And this oxidative stress, this alters the essential cellular functions by gene expression by either upregulation or downregulation. Next slide, please. Okay, thank you. So the animal model is that, so nicotine, it's an active component of cigarette smoke and a predominant toxin. So it acts as a pro-oxidant, that mainly by increasing the generation of free radicals or ROS. So nicotine affects the bovine oocyte cumulus cell expansion, maturation rate, chromosome in a dose dependent and also a oocyte stage dependent manner in bovine oocytes. In case of humans, smoking, which is nicotine is a part of the smoking components, that can reduce the number of mature oocytes even further, thereby risking a negative IVF embryo transfer outcome. And active and passive cigarette smoking increases the zona pellucida thickness of oocytes and embryos. So next slide, please. The plant-derived antioxidant, they are the large group of natural products with reducing or radical scavenging capacity. So development of reliable and eco-friendly approaches for the production of nanoparticles is a key aspect of nanotechnology nowadays. So the objective of the study is that the green biosynthesis of nanoparticles, it's a different technology, has received great attention during recent times. Several of them have been proved as a potent antioxidant. So this is actually a preliminary study. This was initiated mainly to study the effect of green synthesized silver nanoparticles using symphopogon citrate supplementation in nicotine-treated buffalo oocyte animal model during in vitro maturation. This is nothing but a lemongrass or a citronella, we usually call it as. This has a capacity of free radical scavenging and also an antioxidant property. Next slide, please. So this particular has been chosen for the study is that, so the preliminary toxicity studies we conducted using the citronella green nanocolloid. So if you see the images here, so the percentage of oocyte maturation was significantly, it was found to be like of 95.2% enhanced oocyte maturation rate when we are using this green nanocolloid, which is shown in the this oocyte maturation IVM as a control, and B, this is when we are using with the green nanocolloid. So actually this green nanocolloid, this was generously gifted by Dr. Hemalata Srinivasan, Dean BS Abdur Rahman University. Actually patent has been filed for this technology and also for the green nanocolloid. So we have used in this citronella green nanocolloid in this study. Next slide, please. Okay, so the ovaries from non-pregnant buffaloes were collected from the slaughterhouse and they were transported within 2 hours of collection to the Department of Animal Biotechnology, Embryo Production Unit, Tanuvas, that is the Tamil Nadu Veterinary College, and the oocytes were retrieved by slicing method, and oocytes were retrieved in the oocyte collection media, and the selection grading were performed under the stereosome microscope by following Nandi et al. Based on the cellular investment and homogeneity of ooth plasm, and grades of A, B, and C were further chosen for the in vitro maturation procedures. The 50 microliter each droplet, we have put 10 to 12 stimulus oophora cells, and on the pre-equilibrated maturation medium for 22 to 24 hours in a humidified atmosphere, 5% O2, 5% CO2, 90% nitrogen in air. So next slide, please. This was the actual procedure we have conducted. And the experimental design is that there were two experimental conditions. The condition one is that oocytes were cultured in tissue culture medium 199 supplemented with nicotine at a concentration of 5 millimoles. And the condition two is that along with the 5 millimole, we have also incorporated 10 microgram of green nanocolloid. So the first experiment is that to study the effect of different culture media. Culture media were referring to the different conditions on the in vitro maturation of buffalo oocytes. And the second experiment is the gene expression of antioxidant enzymes, BCL2 and the GDF9. These are derived factor, and BCL2 is anti-apoptotic factor during the in vitro maturation of buffalo oocytes. So after the experimental studies, after 24 hours, we have retrieved all the oocytes and they were harvested in RNA later reagent for the further studies. They were stored at -20 till use. Next slide, please. So morphological assessment mainly it was based on the cumulus investment and ooplasm homogeneity based on the Rabindranatha et al. And the oocytes of degree 1 and 2 were subjected for further studies. And gene expression analysis, this was mainly like a conventional, following the conventional method. We have extracted the RNA by guanidine thiocyanate phenylchloroform method. The upper aqueous phase is recovered and RNA collected by alcohol precipitation and rehydration. And cDNA synthesized from all the oocytes utilizing the revert first state stand, the cDNA synthesis. And they were stored at -80 degrees centigrade for further gene expression by reverse transcriptate PCR. The buffalo, well, actually we have worked on the buffalo oocytes. So actually it is a laboratory confirmed one, which is of ethical relaxation. So specific primers we have chosen. GAPDH, this acts as the indigenous control, SOD1, BCL2, GDF9, and GPX4, which were synthesized from sigma aldrich and were used for these studies. Next slide, please. We have conducted also a gradient PCR because multiple primers are involved. So we have conducted a gradient PCR to standardize the non-specific annealing, and gene expression studies were further conducted by a quantitative real-time PCR and in the Quant Studio 6 Plex system. And the CT threshold amplification limit was analyzed using 2 delta CT normalized expression ratio method to determine the relative expression of each mRNA. And it was calibrated using the GAPDH Gauss housekeeping gene. And the expression of GPX4 is 31, everything was shown by 1 by ANOVA, followed by the Newman-Fields test, considering P less than as significant. Next slide, please. Okay, this is the result and discussion. So supplementation with 5 millimolar concentration of nicotine. So if you see, just highlighted in red color. So it is around 61.2 when compared to the control. Control one is 89.81. The maturation rate, that's the cumulus based on the cumulus cell expansion. So in coming to the green alcohol condition, that is the condition 2, supplementation, it is around 83.14%. So values they differ, like it is statistically significant. So this image is shown here, the matured oocytes, which is from the condition 2, we can see the cumulus expansion and all the matured oocytes, and which is under the nicotine supplementation. And 62 degrees centigrade was found as the annealing best annealing temperature. So for further studies, we have used the 60 degrees centigrade. Next slide, please. Okay, the antioxidant, coming to the RT-PCR results, first I'm going to discuss about the antioxidant enzymes. The relative mRNA expression levels of two antioxidant genes. Here we have selected GPX4 and SOD1, showed that GPX4 had statistically significant lower expression levels than the control. However, nicotine and green anacolide supplemented group had only 40% lower GPX4 expression than the nicotine-only group, which recorded 50% less expression levels. And coming to SOD1, there is a significant downregulation of SOD1 in both the group, which is considered statistically insignificant. So normally during a cellular metabolism, as I said earlier, during in vitro maturation procedures, its ROA is going to generate. It would express and rely upon several antioxidant systems. That's a natural procedure. So earlier studies have shown that the influence of nicotine on bovine oocyte, that will be resulting in approximately 21 to 35% of oocytes getting arrested in M1 stage itself. So that shows that reduced metabolic activity, so minimal reactive oxygen species. So naturally, all the enzymes are going to be reduced. So reduced levels of antioxidant enzymes under both the condition than the control shows that maturation rate of condition 2, that is with the incorporated with green anacolloid, was comparatively high with the nicotine only treated group, which clearly indicates that ROAS is kept on control under condition 2 by the green anacolloid. Next slide, please. Coming to the expression of GDF9 and BCL2 under experimental condition. So significant increase in the gene expression levels of BCL2 and GDF9 in buffalo oocytes, whereas addition of green anacolloid, the last one, along with the nicotine, have significantly reduced expression levels related to the control. The last bar, if you see in the last images, both the images, we can see a significant reduction in the expression levels. And in the nicotine stage, we can see a significant increase. This shows that cells are undergoing apoptosis, so that the gene expression is also high. Next slide, please. Next slide, please. Thank you. So GDF9 is an important for growth and proliferation of cells. So though they were upregulated, the highest concentration of GDF9 transcript, they were found abundantly in immature oocytes. So oocytes in condition 1, they have undergoes meiotic arrest, and they remain immature when compared to the high maturation rate that is observed during the condition 2 with nanocolloid supplementation. Means there is an improved developmental competence. The results from this study are in concurrence with expression dynamics of GDF9 transcripts during IVM of buffalo Cumulus luciferus by study conducted by Kadirvel et al., showing that relative mRNA expression levels of GDF9 in oocytes decreased significantly at 24-hour maturation in Cumulus cells. So similar results were also observed in different species during later periods of IVM, that expression of GDF9 was gradually decreased. It means it shows that the oocytes have matured. Next slide, please. The BCL2 protein family is mainly involved in regulation of apoptosis. So earlier studies have well-established relationship between the level of ROAS and BCL2 expression. The overexpression of BCL2 caused reduction of intracellular ROAS levels, that is, oocytes are undergoing apoptosis. So this study has recorded reduced BCL2 expression in green anacolloid pro-treated group, indicating the damage caused by the nicotine in the presence of green anacolloid is less and have attained the developmental competence than the oocytes under the condition 1. So Cinderwish et al. Detected a significantly higher expression of anti-apoptotic BCL2 in atretic follicle in comparison to a healthy follicles. Next slide, please. Next slide, please. Thank you. So please go. Can you please go to the previous slide? Summary. Previous slide. Can you please go to previous slide? Hello. Can you please go to previous slide? Previous slide, summary. Yeah, thank you. The Symphogen citratus derived green anacolloid, the major reason is that increased oocyte maturation rate when compared to nicotine-only treated group that has neutralized the nicotine activity under condition 2. So the current study shows that oocyte maturation rate has improved the presence green nanocolloid without involvement of any enzymatic antioxidant system, which could be explained because of their potent free radical scavenging capacity of capped silver nanoparticles by symphogen citrators. So the continuous studies on supplementation of this green nanocolloid in the next level of ART, including IVF and embryo production, will add more information to this. Next slide, please. Okay, coming to the conclusion, this study actually is a pilot study. This provides a combination of biosynthesized silver nanoparticles and the plant extract citronella as a safe mode of formulation that can be potentially used in future drug development for improving oocyte maturation in smokers, and also a stress buster, can be used as a stress buster during in vitro oocyte maturation process. Thank you very much.
Thank you. It was a nice presentation. It was a in vitro studies. Are you planning for the in vivo studies?
So right now, actually they have filed for a patent, sir, but there is an future scope is there for expanding to the next level of research.
Yeah, it is a implications. Thank you, everyone. We are going late, so it was a very nice presentations all, and we have got the many innovative ideas. Thank you, everyone, and thank you, ACE 2021. Thank you.
Thank you, sir. Thank you, sir, and thank you to all the speakers of the performative series of lectures that we had here. Now moving on to the next segment, which is a mixed bag of lectures. I would like to call upon the the stage Saroj Agarwal, ma'am. It's my honor to introduce her. Can I have the slide, please? Hi, ma'am. I think the other chairpersons are not here yet.
Atita is here. We just need to let her enter because I think she's not being able to enter the hall. I'll just you can introduce.
She's joining.
Yep.
Can I have the slides, please? So it's my honor to introduce ma'am. She is a chief embryologist and scientific director at CARE IVF Kolkata. She has been associated with CARE IVF Kolkata since 2007 and has successfully set up the PGS PGT facility in West Bengal. Has also started the oocyte freezing program, first of its kind in East Vizag 2020. Her interests lie in total quality management of ART laboratory, PGS, PGT, oocyte freezing, sperm DNA fragmentation. She's also the organizing secretary of ACE 2021 and executive member of ACE India. Welcome, ma'am.
Thank you, Rashi.
I would also like to introduce our next chairperson for this session, Atita Shinde, ma'am. Hello, ma'am.
Atita, unmute yourself. Yeah.
Can I have the
hi.
slide, please?
Good morning, everyone.
Good morning. So, Atita Shinde ma'am is a senior embryologist at Mumbai, Powai, and is a consultant embryologist with more than 18 years of experience in the field of human embryology. She's also a trainer for ISAR embryology course over the last 3 years, and has also received ASR certification in 2020. Welcome, ma'am, and over to you both.
Thank you.
Thank you. Good morning, everyone, and welcome you to the third day of ACE. Let's start with the academic feast. We have some very good lectures lined up. So first, the first talk is by Rashida Begum, round spermatic injection, a challenging way of fertility of azoospermic men. Can I have Rashida Begum's CV, please? So Professor Rashida Begum is the Chief Consultant of Infertility Care and Research, ICRC Limited, Vice President of OGSB, Treasurer Aspire. She graduated in medical science in 1982 and completed fellowship in OBG in 1994. She was awarded the diploma and masters in medical education from the University of Dundee, UK in 1997 and 1999 respectively. In 2006, she completed MSc in clinical embryology from the University of Leeds, UK. She completed her PhD in reproductive medicine from Dhaka University in 2014. Welcome, ma'am. We are just awaiting for your lecture. Do we have Rashida ma'am here?
Ma'am, she has not joined yet.
So next speaker.
So then, yes, can we take the next speaker, please, then? Aditya, can you do the introduction, please?
Just a minute. Yeah.
Shailja Gada ma'am, yes. Can we have a CV, please? Himanshu?
Himanshu.
Ma'am, I have not received the.
I have sent it.
Yeah, ma'am.
But ma'am already
Just
there, yes.
yeah, ma'am.
I have it on my first slide. So if I can share my slide.
Yes, please,
Yes, ma'am,
please share it, ma'am, please.
One moment.
Yes, Asita.
Yeah, our next speaker is Dr. Shailaja Gada Saxena. Ma'am has completed MBBS MSc Genetics from UK and she's a PhD. She's in charge of all India diagnostic cord blood, reproductory and stem cells research. Worked in the area of the in vitro fertilization, ovarian tissue cryopreservation, and embryonic stem cells, with the two patents to her credits. One of the pioneers of the pre-implantation genetics diagnosis in India, involved with the COVID-19 testing and handling more than 15,000 tests per day. Current focus in a translation medicine aimed towards cost-effective application of molecular diagnostics testing in the diagnostic prognostic and in tragic therapy. Dr. Gada Saxena has authored several publications and several as a reference for the number of the scientific journals. So next speaker is ma'am, Dr. Gada Saxena.
Thank you, Aditya. Thank you, Dr.
Yeah.
I'm not able to put this on a slide view actually. I've sent my slides also.
Himanshu, if you can play it from your side.
Ma'am, let me find.
It's too small to see actually.
So I'm just not able to put it on the slide view.
Can you try resharing it like once more?
Yes, ma'am.
Till that time, maybe they can do it. Yeah, if you can just try resharing it.
Yeah. Is it visible now?
Yes,
Yes, ma'am.
Yeah. Sorry for the delay. Good morning, everyone. So the topic of my presentation today is chromosomal aberrations in reproductive failure. And I'm going to cover the very basics of the chromosomal aberrations, stick only to the topic of chromosomal aberrations because we get a lot of patients and most of the times we are not sure how to handle those patients or what to counsel them about. So I'm trying to cover the most basic on how you manage these patients and what are the basic investigations that you need to do. So just as a background of what is genetics, most of the gynecologists try to run away from the topic of genetics because they think it's something hi-fi, but it's not really, it's something very simple. We all say I have my father's laugh, but my mother's sense of humor, my mother's temperament, but my father's temper, my father's mouth, but my mother's taste. So we are basically a concoction of the family to which we are born. And this is all carried in the form of our genetic information. So how is this genetic information organized or carried? This information is carried in the foundation level molecule, which is known as the DNA. The information in the DNA is organized into the genes. The genes in turn make up of the chromosomes, and every cell in the individual contains the entire genome. So here basically in this presentation, we are going to focus on the chromosomes and the chromosomal aberrations and their role in reproductive failure. Now, just again to basically a quick recap on genetics. So this information is in the form of 23 chapters known as the chromosomes. Each chapter contains several thousand stories known as the genes. Each paragraph is made up of words written in the letters known as the base pairs. And all this information is as long as 800 Bibles. So think about it. Each cell in our body contains information which is as much as 800 Bibles. And what does this information translate into? So this is something like a history textbook, which gives information about our relatedness to other members of the species. It is like a developmental biology book which gives information about how the human develops from a sperm and an egg. And it is like a medical textbook which gives information on the understanding, prevention, and cure of the disease. So with this basic background about genetics, let's come on to our core topic for today. So business of babies, as we all know, the reproduction is a messy business. Having a child is everyone's life's most important and momentous task, and yet it can be the most unpredictable and uncontrolled. Not all pregnancies go through a completion, and there we do face problems like miscarriages, infertility, genetic disease, which cause a lot of pain and suffering to individuals. So for this, we need to understand basically what do you understand by reproductive failure and what are the different causes. So reproductive failure basically encompasses two things, infertility and bad obstetric history. As we all know, infertility occurs in 1 in 7 couples, with male factor contributing to 40%, female factor to 40%, and combination in 20% of the cases. While on other hand, bad obstetric history is seen in 15 to 20% of all recognized pregnancy. And majority of these are first trimester miscarriages. Now, the etiology for this can be varied, including anatomical factors, infections, endocrine disorders, immunological disorders, and chromosomal aberrations. So in this presentation, I'm going to cover only the most basic chromosomal aberrations. Now, coming on to chromosomal aberrations, these can cause various manifestations in an individual, right from primary infertility or sterility in men and women, pregnancy losses, congenital malformations, ambiguous external genitalia, primary amenorrhea, male gynecomastia, male subnormality, etc., etc. So just a quick recap on what are the chromosomes. So chromosomes, we all know that we have in humans 46 chromosomes, that is 23 pairs of chromosomes, of which 22 are autosomes. And there's a pair of sex chromosomes. And these chromosomes are analyzed or studied by what is known as karyotyping. So karyotyping, just to understand briefly, is an organized profile of a person's chromosomes. And chromosomes, as we all know, are best analyzed at the metaphase stage of cell division. Now, there are different kinds of chromosomes. We don't need to understand all the basic details, but just to understand, there are different kinds of chromosomes which are based on the size, the position of the centromere, and the banding pattern. And this is how a normal karyotype looks like. So when you get a report, this is what exactly you would be seeing in the report. Now, coming on to different kind of chromosomal aberrations, it's very important to understand these because when you get a report and you need to counsel your patient, you need to understand these basic terminologies of what are the different kinds of chromosomes. So as I said, each human has 46 chromosomes. Anything more, less, or different from this is what causes a chromosomal aberration. So there can be numerical and structural chromosomal aberrations. Numerical chromosomal aberration again are of different varieties. Like if you have a loss or gain of chromosome, it is known as aneuploidy, which is mostly in the form of monosomy, as seen in case of monosomy for X chromosome, the Turner syndrome, which we all know about. Or then there may be trisomy, as the compatible ones that we know are trisomy 13, 18, 21, etc. Then there may be polyploidy, where an entire set of chromosome is replicated. So as against aneuploidy, where there is a loss or gain of a single chromosome, we have polyploidy, where the entire set of chromosome is replicated. This is in the form of triploidy or tetraploidy, as seen in case of products of conception. Then you have something known as the structural chromosomal aberrations. So any variation in the chromosome structure than the normal is known as structural aberration. This may be in the form of translocation, the reciprocal translocation, and the Robertsonian translocation. So I think these images are self-explanatory. In case of reciprocal translocation, there is exchange of chromosomal material between two non-homologous chromosomes. And in case of Robertsonian translocation, it is seen in case of acrocentric chromosomes, where one chromosome comes and sits on top of another chromosome. So in this case, there is no loss or gain of chromosomal material. So per se, the individual carrying this translocation would be absolutely normal. However, it's only at the time of gamete formation, when the gametes are abnormal, then this comes into light. Then there is something known as inversion. Again, where a part of chromosome breaks, turns upside down, and attaches at the same position. Again, if it's not passing through the gene of interest, then it would be asymptomatic. Then there's something known as deletion, where a part of chromosome is lost. Again, depending on the segment which is lost, whether it has genes of importance, it may be symptomatic or asymptomatic. Then there's something known as ring chromosome, where either sides of the chromosomes are broken, and because of which it becomes sticky and forms a ring-like structure. And then you have isochromosome, mostly seen in cases of Turner syndrome, where one arm of the chromosome X is lost and there is duplication of the other arm, resulting in overdosage of the material present on the Q arm, while underdosage of the material present on the P arm. So with this basic introduction of different kinds of chromosome, let's understand how they cause the reproductive failure. So most of the individuals who are carriers of these chromosomal aberrations, these are balanced, and as a result, the individual will have no symptoms at all. These are phenotypically normal individual who only present in the form of infertility, recurrent pregnancy loss, or if in case they have had a child with some kind of abnormalities. So this is one very basic testing that we need to do when the patient come to us with infertility, recurrent pregnancy loss. We do a wide variety of testing for these patients, forgetting the most basic testing of karyotyping, because there's a lot of information that we can get from this, and the entire management for the patient changes if we identify a chromosomal aberration. And the occurrence of this chromosomal aberration in cases of reproductive failure is as high as 2 to 4%. So at least if we identify this basic problem, then the entire management would change, and we would save upon a lot of time for the patient by doing this basic investigation. So what happens is basically at the time these individuals are normal. If you see this picture, this is the normal chromosome, and these are the translocated chromosome. So now if this normal chromosome along with this abnormal chromosome comes, then is when we would have problem. Or again, this normal chromosome and this abnormal chromosome, if they come into the individual, then there is a problem. If both the abnormal chromosomes come, then again the child or the would be having the same kind of translocation as the parent, but would have no symptoms at all. So this is something which is important to keep in mind, because this would help in prenatal diagnosis as well as in case of counseling of the patient. So there are different kinds of chromosomal aberrations that you come across. So it is not something specific that each patient that comes to you would have the same kind of chromosomal aberration. It may affect any of the chromosomes, and hence you need expert to analyze these cases. And then as an obstetrician or a gynecologist, you along with the geneticist need to take part in counseling of the patient and guiding the patient for the further course of management. So as I explained in my earlier slide, this is how the gamete formation occurs. And if it's both the normal chromosomes or both the abnormal chromosomes, if they take part in the gamete formation, then there is no issue. However, if one normal and one abnormal, as in these cases, take part in the gamete formation, then the fetus that is formed is going to be abnormal. And as a result, it would result either in infertility or in cases of recurrent abortion, because it's the nature's way of discarding what is not normal. So most of the time you would have these patients with recurrent miscarriages or a prolonged infertility. And only on karyotyping you would come to know what is the exact cause of this disorder. So the earlier slide showed about the reciprocal translocation, and this is how the Robertsonian translocation take part in chromosomal aberrations. Now, apart from these numerical and structural abnormalities, you may have something known as chromosomal mosaicism. Now, chromosomal mosaicism is like presence of two or more different cell lines of different genetic constitution in an individual. It can occur in any of the tissues or cells in the body. However, in our case, our area of interest is the gonads. So when you have gonadal mosaicism, then there is an issue, because these are the cases which would have abnormal gamete formation. So when you have mosaicism or the abnormal cell line restricted to the gonads, it is known as gonadal mosaicism. And X chromosomal monosomy is usually associated with follicular atresia and gonadal dysgenesis. And monosomy for X chromosome, the mosaicism, is associated in 20% of spontaneous abortions. Now, again, this is the set of individuals who are absolutely phenotypically normal, and hence the gonadal mosaicism would be difficult to diagnose. And in routine, how it is diagnosed is by gonadal biopsy and tissue culture. Now, that is an invasive procedure. So we have come across a new test. We have developed a new test which is known as the follicular fluid fish. And just to explain this, low-grade gonadal mosaicism would result in aneuploid gametes. And when the gametes are aneuploid, naturally the embryo's form would be aneuploid. So this follicular fluid fish testing that I'm talking about, as we all know, during the IVF process, the follicular fluid is a byproduct which is discarded after we pick up the oocyte from that fluid. Now this contains the cell from the gonad. So if we do analysis of this, it would give information about the low-grade gonadal mosaicism in the individual. So, we have done a study of more than 500 patients and seen that all the couples who have, or all the females who have low-grade gonadal mosaicism, they have a lower pregnancy rate and a higher abortion rate. So it's important to do this again, simple test of follicular fluid fish for these couples to rule out low-grade gonadal mosaicism. And it necessarily does not need to be done only in IVF patients. You can even do it in non-IVF patients by a simple OPD procedure of gathering the follicular fluid and sending it for testing. Most important to do this testing in cases of recurrent spontaneous abortion, polycystic ovarian syndrome, premature ovarian failure, and in cases of gonadal dysgenesis. Since I'm not talking about the other investigations and only restricting myself to chromosomal aberration, another important test to do in cases of male infertility is to rule out aneuploidy in the sperms, because it's seen that in infertile men, there is a tenfold increase in chromosomal aberrations. So a simple, we all know that a normal sperm should be haploid. So it should have one signal for each of the chromosomes, like this one is for 13 and 21, this is for X and 18, this one is for Y and 18. So all these chromosomes are labeled with different color fluorochromes. Well, this one is an abnormal one because it has both the X and Y chromosome along with chromosome 18. So now in case this sperm goes and fertilizes the oocyte, then the oocyte would already have one X chromosome. And here this sperm would carry one X and Y. So the embryo that is formed would be XXY. That is the Klinefelter syndrome. So it is important to rule out the percentage of sperms having aneuploidy because it will help in better patient management. Then you have something known as the sperm DNA fragmentation analysis, which helps in analyzing the DNA integrity. Now again in cases of, so this was with infertility. Now in recurrent abortions, again we know that incidence of spontaneous abortion is 16% of all clinically recognized pregnancy, and it's known as recurrent spontaneous abortion when you have had 3 or more miscarriages, and the incidence of having chromosomal aberration in these cases increases multifold. And this information is something which has been known for years together. As early as 1976, this was reported. So again, an important testing to do is karyotyping or FISH testing on products of conception, because that will help in better patient counseling and management. Because if they have had chromosomal aberration in the products of conception during this pregnancy, then there are chances of having chromosomal aberrations in subsequent pregnancies is going to be higher. So this is an example where you have 3 signals for each of the chromosomes instead of 2 signals, which is indicative of triploidy. This is a similar case where you have the karyotyping showing triploidy. So instead of 2 chromosomes, you have 3 chromosomes for each of the pattern. And then this is a case where you have 2 aqua and 1 green, so monosomy X, again seen in products of conception. This is a case of Klinefelter syndrome, so you have 2 X chromosomes and 1 Y chromosome. I have labeled it here with different colors. So basically, each chromosome is labeled with a different fluorochrome. So here you see 2 aqua signal, which is for chromosome 18, then 2 X and 1 Y. And then based on these information that you get, it is important to do the testing on the fetus, which may be in the form of amniotic fluid sampling or chorionic villus sampling, to rule out any chromosomal aberration in the fetus. So a very important test which we need to do whenever we are suspecting any kind of chromosomal aberration in the fetus. Now, quickly, I'll take you through some of the case studies and how they help in like how this basic testing of chromosomes is important in further management for the patient. So here is a case where we had an 11-year-old girl with short stature, swollen hands and feet and webbed neck, who was referred to us with a query of Turner syndrome. And we analyzed 35 cells which had 45 chromosomes, and then there were 15 cells which had a 47 XXX kind of pattern. So this was a mosaic case where you had some cells with XXX pattern and then some cells with single X pattern. So again, once you have diagnosed, then it's easier to manage the patient and counsel the family. Another case, again, we had a 17 years old patient who was referred to us with short stature and primary amenorrhea. Now, this was a very interesting case where we saw 46 chromosomes with the X chromosome, but then the last chromosome was neither a Y chromosome nor an X chromosome. So the pattern did not match either the X chromosome or the Y chromosome, as you see in this case. So we did a complementary FISH for this patient just to ensure that what was this chromosomal aberration. And this was 2 copies of the Y chromosome sitting on top of each other. So they, again important. So this was basically a female, phenotypically female, but she had XYY pattern. And again, the chromosomal count was normal. So if you had done this testing at a normal center, not having too much of expertise, they would have possibly labeled it as X chromosome or a deletion in X chromosome. But actually, this was a case of XYY. Another case where we had a 21 years old female with a not a short stretcher but a tall stretcher, but primary amenorrhea. Sonography showed a small size uterus and ovary. Again, the doctor suspected Turner syndrome, but when the sample was sent to us, all her metaphases showed the XY pattern. So basically, this was an XY female, phenotypically female, but karyotypically she was a male. So karyotyping, as I mentioned, becomes a very important first line investigation to be done for these couples having various indications, or in cases of spontaneous abortion, or in cases of primary amenorrhea. Again, another case, very interesting one, which we published also, where we had a 3-way rearrangement. So a 25 years old phenotypically normal patient who presented to us with 3 spontaneous first trimester abortions. And she had a 3-way translocation that is involving 3 chromosomes, chromosome number 7, 13 and 15. So it's important that you send your karyotyping testing done with a expert laboratory with a lot of expertise, because it becomes very important in patient management.
Excuse me, ma'am, you'll have to just hurry up a little
This
because we've
this
already,
is my
yes,
last slide.
yes.
So
Thank you, ma'am.
basically, this helps in identifying further course for patient management in terms of genetic counseling, in terms of explaining the patient on the recurrent risk estimation, counseling them for prenatal diagnosis and subsequent pregnancy, or whether they should go in for pre-implantation genetic diagnosis, or in some cases, it's best to counsel them to go for donor sperms, donor eggs, donor embryos, or for adoption. So a very basic investigation which can help the patient a long way in achieving the goal of having a normal, healthy baby by going on the right direction. Thank you very much for a very patient hearing, and I'll be happy to take up any questions.
Thank you, ma'am. That was a wonderful presentation. I was just wondering if everyone did a karyotype, things would have become so much easier for the reproductive this thing. And what I really loved about was the gonadal mosaicism, what you discussed. I don't think anyone is checking the follicular fluid, doing that FISH test for that. But then how good would it be to just screen everyone's follicular fluid unless you don't know? It's like just as you suggested, maybe patients of polycystic syndrome and all that, we can try it. But there has to be some one marker where people feel that, we can actually go ahead with this. How do we come to know whether the patient has a gonadal mosaicism there?
See, basically, we had done it to begin with infertility cases where we had a lot of, so we had carried out this study on 500 patients with infertility. So repeated IVF failure is what we started with, and we saw that these patients had
very high, whichever patient
Yes.
had low-grade gonadal mosaicism, they either did not conceive as compared to the controls with the same age group and similar kind of symptoms. And in case they conceived, then the chances of abortion was very high. Unfortunately, I don't have the slide with those numbers. And later now we have started offering it for patients with a risk of premature ovarian failure or repeated abortions of various other indications.
Okay, ma'am. Thank you, ma'am. We'll take some other questions after our other speakers. So please be there in this session. Now, I would like to invite Dr. Charudat Joshi. Can I have his CV, please? Charudat is speaking on prevention of contamination, including fungal, bacterial, viral infection in IVF culture. Dr. Charu doesn't need any introduction. He's one major person and president in ACE. He's done his post-graduation in life sciences in 1993. He's done a special training in ICSI IVF sperm morphology from Genk, Belgium. Done special training of embryo freezing from KK Women Singapore. He has done special training in laser assisted hatching from Belgium. Done a special training in PGD from Germany. Done doctorate in life sciences in 2018. He's an executive member of MP SAR chapter, MP IFS chapter, and executive committee member of SR. Past Vice President, ACE, Academy of Clinical Embryologists, past Vice President, Academy of Clinical Embryologists 2014 and 16, and is presently working as a medical director in Genes India ART Bank. We have a pre-recorded lecture of Charudat, sir. So can you just play the presentation, please?
Thank you, ACE 21 organizing team for providing this opportunity. My today's talk is on prevention of contamination, including fungal, bacterial, and viral infection in IVF. As we all know, this contamination is a very big issue, and it's a very important aspect to be covered under ART center, because any ART center has to have zero contamination in the culture conditions, so to achieve the good embryos and good pregnancy. Now, according to dictionary definition, contamination is defined as the process of making something dirty or poisonous, or the state of containing unwanted or dangerous substances. That means something unwanted, if it comes in your system, that is considered as contamination. And believe me, it is a nightmare for the lab, as once it comes in the culture system, it is very difficult to get rid of contamination. Why it is cause of worry? Because in ART procedure, if contamination occurs, then there is chance that the laboratory staff exposed to it, the patients, doctors, embryologists, everyone get exposed to it. As we do not know the nature and source of that contamination, so it is of concern and has to be given attention urgently. Now, I would just like to emphasize on ART procedures and the microbiology, as they are very closely related during development. So both of them evolved almost simultaneously, as after discovery of animalcule, which is actually a sperm. After that, many workers have worked on this, and they developed the ART procedures. ART is a multidisciplinary field which requires teamwork and collaboration with different medical and scientific disciplines, including microbiology. That is an integral part of our system. We need to do the cultures of semen samples or the follicular fluid, or just to know about the microbial status. Culture media, culture systems are their important part of this ART procedure, and they are also developed to support growth and development of gametes and embryos. So now here the key point is that the culture media is something which offers everything for a good growth of any organism, as it supports the culture system, the gamete and embryos. So it is very easy for any microorganism to grow in this medium. But as I said, this also encourages growth, and the cell division in pre-implantation embryos is a slow process, but microbes have the ability to multiply very rapidly under favorable conditions. So why this all is there? Because it is of concern, because microorganism doesn't need that much of time. Our cell has a definite cell cycle. There is a definite time period in which it divides and then it redivides. But as far as microorganisms are concerned, they are very rapidly dividing. They can survive in extreme adverse conditions for a long time, like bacteria can form spores, viruses can survive dry on many surfaces. Now, this is matter of concern. These properties of microbes present special challenges in ART laboratory as chemical agents used to control them are toxic for gametes and embryos. Now, it is always advisable that an ART laboratory should have a strict guideline for maintaining necessary sterile conditions without compromising the gametes and embryos. And what we mean by this slide is that although microbes can be controlled, they can be cleaned, but the methods and chemicals used are toxic. And that's why if you follow a strict guideline and strict quality control procedure in our lab, then these chances of contamination can be zeroed down. Now, let's talk about the type of microorganisms we come across. They are broadly categorized into bacteria, fungi, viruses, prions, and parasites. What kind of infections we find in ART procedure? So the very simple STDs and other diseases is blind as herpes simplex virus, Trichomonas vaginalis, Candida species, Denital papilloma virus. These all are naturally present, and it can be of concern if this patient is undergoing IVF treatment or ART cycle. So these all blood-borne viruses like CMV, HBV, HCV, HDV, HIV, these all has to be taken into consideration. Now, what can be the source of infection? Either it can be a patient, because patient is coming from outside in your culture system. Specimen collected like blood, aspirate, oocyte, semen, embryos, testicular or ovarian tissue. Staff hygiene, laboratory supplies like media, water, disposable, environment, air, gas mixing, air conditioner, walls, floors, so on. So anything can be source of infection. Now let's discuss it one by one. The semen, it's a genitourinary tract. There are, when it is developed in the testes and then it comes out, it goes through a definite tract, which we can call it a genitourinary tract, from where it comes out, and it may have many kind of infection in it, like Carinibacteria, Neisseria. Skin flora is also there, Staphylococcus, E. coli, Klebsiella. So there are many kind of infection source is there in the semen, and that's why it has to be taken very carefully. Usually it is in common practice that we get the culture done well in advance before putting patient for ART procedure, so that if there is any infection, we can control it. Otherwise, on safer side, all patients receive a broad spectrum antibiotic course. To control this, SOP, standard operating procedures, collection, processing, use of antibiotics, these all can be given, this can be used to control it. But virtually, if we see some kind of infection is always there, only we can suppress it. We cannot get rid of infection 100% because it can come in any form from anywhere. Now talk about oocytes and embryos. Again, this is a genitourinary tract, is the passage from where the oocytes comes. Transvaginal oocyte retrieval procedure, fecal contamination, follicular fluid. Females are often asymptomatic for STDs. So this is another important area. So there is no symptoms. And then use of antiseptic for vaginal cleaning is not recommended, as it can cause adverse effect on the gametes and embryos, and so on. So all precautions has to be taken care during culture of embryos, and aseptic technique to be followed just to get rid of this infection or contamination. Now, this is a picture taken from the book which shows fungal and bacterial infection, yeast contamination and fungal contamination. Now come to other factors. This is the patient factor which we talked about. Now other factors is like laboratory environment. It can be again categorized into two parts, inside and outside. Inside is the laboratory atmosphere, outside is the air conditioning, positive pressure module, material, supply, media, disposable. Like we discussed earlier, the source of infection can be anything. Cryo storage tanks, storage and transfer of gametes and embryos, contaminated liquid nitrogen, leakage in cryopans. It is reported that HBV, HIV, and HCV-like organisms can survive in liquid nitrogen. So all that precaution need to be taken care during cryo storage, also in the tanks also. We'll discuss it in future slides, coming slides. Now we have to understand few terminologies, which is more of confusing kind. One should be able to differentiate what we are exactly meaning by the terms. So sterilization is the use of physical or chemical agents for complete removal of living organism. Disinfection is the term used for chemicals in order to destroy potential infectivity of an organism, and it can reduce but not necessarily remove them. Antisepsis is a topical application of chemicals to body surface to kill or inhibit pathogenic organisms. Antiseptic is a disinfectant used on this living tissue. Sanitization, this is a very common word we are listening nowadays in COVID era. So reduction of microbial population to a safe level recommended by WHO. Then decontamination is a collective term used for removing microorganisms and by use of any above method. This is in total is called as decontamination. Now, sterilization methods, we have physical methods, we have mechanical methods, we have chemical methods. All of them have their advantages and disadvantages. So selection of that sterilization method depends on where you want sterilization, what you want to sterilize. So physical sterilization, the very commonly used factor here is the heat, which is most effective method of sterilization for all heat stable material. Now it is important that if you are applying heat, then that material which is to be sterilized should be able to take that high amount of heat, high degree temperature. It's not suitable for protein containing substances. All mechanisms are susceptible to heat, and that is the mechanism of destroying the microorganisms. Thermal death point is a term used which refers to the lowest temperature at which exposure of 10 minutes results in destruction of microorganism. So this may be different for different microorganisms, but this is a term. Now heat can be applied in two forms, either dry heat, that is incineration, hazardous material. Dry heat, there is no water content. We are just heating the entire thing to a very high temperature. And the very common application of this is like incineration. The hazardous material is burned at 980 degree. Oven sterilization, 180 degree to 1.5 to 3 hours. Then moist heat is, we know the boiling in water at 100 degrees centigrade for 15 minutes is the best or the most common method which used in the earlier days. We have autoclave, where at 15 pounds per inch pressure or 1 atmosphere pressure for 15 minutes at 121 degrees centigrade, the material is autoclaved and it is free of microorganisms. As we go high altitude, more pounds per inch pressure is required. Pasteurization is a common term for pasteurizing, mostly used for the milk. It is rapid heating at 72 degrees centigrade for 15 seconds or 63 degrees centigrade for 30 minutes. It is mostly used for milk industry. Now, another part of physical sterilization is the radiations. We can have ionizing and non-ionizing radiations used for sterilization. Ionizing radiations like gamma rays has high energy. This is the mechanism of this radiation is that because they have high energy, they produce free radical which cause destruction of protein and DNA of the microorganism. And like for plastic wares, this is one of the common methods used. Non-ionizing radiations like UV rays has low energy, low penetration power, and then they cause thymine dimer formation, thus stopping transcription and translation, and that's how it stops microorganisms growth. Now come to mechanical sterilization, we have filtration, cellulose acetate or nitrate membranes with pore size of 0.1 to 0.45 micron. It removes most of the bacteria but not viruses. Used mostly for heat sensitive material like media filtration. Air is filtered through HEPA. We all know we have HVAC system in place for maintaining the sterile air in our culture condition. Ultrasonic waves, they are high frequency waves which cause high degree of vibration and which disturb the protein and lipid membrane constitution of the microorganism, and thus the microorganisms are controlled. This kind of method can be used for sterilizing instruments, needles, or pipettes. Now we have lots of chemicals available for sterilization, but as we know, gametes and embryos are very sensitive, and our lab conditions are also very sensitive to the chemical concentration, and also all of them are not be applicable in our ART lab. But some of them are commonly used with ethylene oxide, alcohol, aldehydes, halogen peroxide, quaternary ammonium compound, and they are again, as I said earlier, that their use and their selection depends on what you want to sterilize and where you want to sterilize. Now, other infectious agents like I said, viruses, they are very typical and they are very difficult to handle. So it can be disinfected by soaking in 10% sodium hypochlorite for 1 hour. But we mostly don't have any viral contamination coming in our culture conditions. Prions, this is in simplest form of the, you can say it's a kind of DNA, RNA substance which has no effect by any of the agents. WHO recommend to control these prions to soak it in 12.5% bleach for 1 hour at 20 degrees centigrade. And as I said earlier, that selection and selection of that disinfectant is dependent on the influence, how it acts, how quickly it acts. So several factors influence the activity of a disinfectant, like type of organism, for temperature, pH, load of microorganism, concentration of disinfectant, nature of surface, contact time, amount of material. These all are the parameters which we as an ART specialist or an embryologist or in the ART conditions, we need to consider all of them, all these factors to find out a suitable disinfectant for us. Now, in selection, we can have another parameters like spectrum, how many, we prefer usually the broad spectrum one, rapid and having irreversible effect, stability, no adverse effect on equipments, ease of use, less toxic to human being, no residue or odor, and highly biodegradable. Now come to air quality. As I said, it's very important requirement because everything of what we are doing is under this sterile air, and we need to check the quality of air very frequently, and that's why HVAC systems are designed which keeps on circulating the good quality air in the atmosphere. Now, air quality is differently required for different industries. Like pharma industry may have different requirements, space industry may have, research industry, food industry, they have different requirements. They need a quality air circulated during the process. It is classified on basis of number and size of particle within a sample of air and measured as particle per cubic feet or cubic meter. And these standards are laid down by ISO, International Standard of Ionization, Switzerland. So this is the agency which decides class 1, class 2, class 3. This terminology is used. Now, clean room technology, it is achieved by using HEPA filters in air handling unit. Filtered clean air moves across area at a constant rate of 0.3 to 0.45 meters per second. ISO, according to ISO, defined clean air is class 1 to class 9. Lower the number, cleanest is the air. For pharmaceutical and biological lab, class 2 clean air atmosphere is recommended. Now, to take care of VOC, a very commonly used method is activated carbon. It can be used to control VOCs in the lab. From time to time, microbes with effective handling, cleaning, maintenance, aseptic conditions, following SOP, there is no need. Basically, there is no need. We don't go for every month or every week culture in the system. But once a year, it is advisable to take plates, swab cultures, or few methods which is applied in the lab to know about the air quality. These are the control measures should be taken. Air infiltration unit. Comprehensive, what is the remedy? Remedy is comprehensive visual inspection and regular cleaning should be able to control it. Some common examples are zygomycetes, rhizopus, mucor, aspergillus. These are the most common area, which is mostly at the damp places we see this fungal contamination and spore. And always in cleaning schedule that after this time period, the time interval, this need to be cleaned. This should be an integral and important part of the total quality management for everyday ART laboratory procedures. Sterilizing instruments and other agents should be regularly monitored for its performance. Well-defined protocols will be of great help. This is the key of success. And with this, I conclude my presentation about these infections. This is really of serious concern. Once it happens, then it is difficult to get rid of it. I would like to mention here that the references in this topic is taken from a wonderful and classical book on infections, infertility, and assisted reproduction by Dr. K. Elder. Thank you very much.
Such a wonderful lecture. Hello.
Yes, Adita, go ahead. We can hear you.
Yeah. Such a wonderful lecture, sir. But we are running very short time, so we are going ahead with the first lecture. Dr. Rashida Begum is here, so we will start with her lecture. Hello.
Hello.
Can
you hear me?
Yeah. Rashida ma'am is a professor. Is a professor. Dr. Rashida is like a chief consultant in the infertility care and the research center ICRC Limited, vice president of OGSB, treasurer Aspire. She graduated in the medical science in 1982 and completed fellowship in the obstetrics and gynecology in 1994. She was awarded diploma and a master's in medical education from the university in Dundee, UK in 1997 and 1999 respectively. In the 2006, she completed MSc in clinical embryology from the University of Leeds, UK. She completed PhD in reproductive medicine from Dhaka University in 2014. And ma'am's lecture on round spermated injections, a challenging way of fertility azoospermic man. Ma'am, now stage yours. Please start.
Thank you. Thank you for your kind introduction. I am sharing my screen.
Yeah, please.
Why it is not coming?
Hello?
Yes.
Yeah, ma'am. Is it possible?
It is not.
Is there any problem?
No. Yes. When I am going for sharing screen, I'm seeing this screen, but I'm not seeing my slides.
Okay.
I don't know what's happened today.
Just a minute. Your slides there? Hello? Just a minute.
Yes.
Your slides are there.
Can you please help me?
Ma'am, so what are you seeing right now on the screen?
Just I'm seeing this screen, your screen, but I can't see my slide.
Ma'am, are you trying to share your screen with the Zoom?
Zoom.
Do we
Yeah.
have her slide?
No, ma'am.
Okay.
Screen share হচ্ছে না।
Screenshot?
Screen share হচ্ছে না তো।
Screen share হচ্ছে না?
হুম।
এই তো enter screen.
Yes, started.
Ma'am, we can see your screen now. Just share your slides. Open your slides. Yes, ma'am.
Yeah.
Yes, ma'am. Now it is visible. Just make it full screen. Yeah. Ma'am, please unmute yourself from other device.
Are you facing any problem, ma'am? We can see your slides.
Ma'am, you just have to unmute yourself.
Can you hear me?
Yeah, we
Ma'am,
can hear you, but
now
we can't
you
see your
start.
slides.
Yeah, now you start sharing your screen.
Now it's okay? Okay?
But we can't see your slides, ma'am.
Rashida ma'am, can we do one thing? Can we start with the other lecture?
Other lecture, yeah.
Dr. Stephen Fleming is waiting. We can come back to your lecture after the keynote lectures. Sorry for the trouble, sorry for the inconvenience, but we are getting very late. So just give us some time.
Yes,
we'll get back
of
to you
course.
later.
Yes.
Yeah, please.
Priya, are you here? Adita, can you just introduce Dr. Fleming and we can start the keynote lecture, please?
Yes, please.
I think Priya is here. Priya is here.
Priya ma'am, are you there? Yeah, Priya ma'am is. Ma'am, please go ahead. She's unmuted. She's muted.
Yeah, I just arrived. Thank you so much. Sorry,
Yes, Priya.
there was a delay in the other session.
Priya, please introduce Dr. Stephen Fleming and carry on the lecture, please. I'm in Hall C now. Yep.
Thank you. So it is always a pleasure to introduce Dr. Steve. He's a director of embryology for Cooper Surgical Fertility and Genomics. From 1993, he's been appointed as a lecturer of obstetrics and gynecology in University of Nottingham, England, where he established the world's first master degrees in assisted reproduction technology with Simon Fischel. From 1998 to 2008, Steve was the scientific director of Westmead Fertility Center in Sydney and was been appointed as a senior lecturer of OB-GYN in the University of Sydney. Over to you, Steve, for the wonderful talk.
Thank you, Priya, for that very kind introduction. I'll just share my screen.
Yes, please. And it's always a pleasure to see you and meet you, Steve.
Thank you. So I trust you can all see that.
Yes,
so,
we can.
Good afternoon, India. Nice to be here. So I'd like to thank the organizers of this ACE 2020 conference in Kolkata for inviting me to speak to you today. I shall be reviewing the evidence for the use of culture media containing granulocyte macrophage colony stimulating factor, and I'm going to pay particular attention to its use in the treatment of poor prognosis patients. So it's well known that the clinical outcome of assisted reproduction treatment is dependent upon many factors, primarily maternal age, reproductive history, duration of infertility, and indications for assisted reproduction treatment, such as uterine, male, hormonal, and immunologic factors, and also idiopathic infertility. So based upon such criteria, patients are often classified prior to their treatment as having either a good or a poor prognosis. So here are the main ways in which a poor prognosis may present. So firstly, repeated implantation failure in subsequent cycles, despite the transfer of good quality embryos. Then we have recurrent miscarriage, which is defined as 3 or more consecutive spontaneous pregnancy losses at less than 24 weeks of gestation. However, a study of over 1,000 women found that the likelihood of detecting an abnormality after 2 or after 3 or more clinical losses is actually similar from conception to 24 weeks gestation. Recurrent miscarriage is thought to have multiple etiologies, including parental chromosomal anomalies, maternal thrombophilic disorders, immune dysfunction, and various endocrine disturbances. However, none of these conditions is specific to recurrent miscarriage or always associated with repeated early pregnancy loss. So lastly, amongst the others, advanced maternal age is also associated with a poor prognosis, as we know, and this is primarily for genetic and phenotypic reasons. But we shouldn't forget that poor clinical outcomes can also arise due to iatrogenic effects. So with poor prognosis patients, we can look at gamete quality, fertilization, embryogenesis, and implantation, and these represent the primary targets for their treatment. In this respect, sperm morphology may influence fertilization, but it's the integrity of the sperm DNA which will impact embryo viability. Oocyte quality is an inherent reflection of a patient's reproductive age and health and will largely determine embryo quality. However, there may be ways in which we can culture embryos to improve their competence to develop, implant, and produce a viable pregnancy, which is the subject of this presentation. Now, whether a blastocyst implants and whether miscarriage is avoided is likely to depend upon the dialogue between the embryo and maternal tissues. And there is one class of signaling molecules within the reproductive tract known as reproductive cytokines. These cytokines may have trophic or apoptotic effects and mediate autocrine, paracrine, juxtacrine, and endocrine signaling. In vivo, the embryo is exposed to a dynamic mixture of growth factors and cytokines as it moves along through the oviduct and into the uterus. The cytokine environment in the periconception period is actually a balance between apoptotic and anti-apoptotic factors, which influence gene expression, metabolism, cell stress, and apoptosis pathways in the pre-implantation embryo to initiate downstream events impacting implantation, placental development, and fetal growth, and ultimately the phenotype and health of progeny. Therefore, what is the scientific evidence and rationale for supplementing culture media with growth and survival factors? Well, if we look at this very nice study using immunofluorescence staining for a range of cytokines and growth factors and their receptors, so you can see the ligands in the left-hand panel and the receptors for those ligands in the right-hand panel, and you can see the green staining corresponding with the immunofluorescence. You can see that these human cleavage stage embryos are able to both produce and respond to a wide range of signaling molecules. And these include, in this study at least, epidermal growth factor, insulin-like growth factor, GM-CSF, brain-derived neurotrophic factor, colony-stimulating factor, artemin, and glial cell line-derived neurotrophic factor. And what's interesting is that if you use monoclonal antibodies to those very same cytokines and growth factors, and here you can see gel electrophoresis on the left-hand side and immunohistology in the right-hand plate, you can see that all of these cytokines and growth factors are also expressed and secreted by the human endometrium during the mid-secretory phase of the menstrual cycle. So why are we particularly interested in GM-CSF? Well, decades of basic research have demonstrated that embryogenesis, implantation, placentation, and fetal development are regulated by growth factors and cytokines, such as GM-CSF. The GM-CSF molecule, receptors, and signal transduction pathways have been extensively researched and characterized down to specific molecular interactions and physiological functions. The expression of GM-CSF increases within maternal tissues during pregnancy, and it directly stimulates embryonic cell growth and differentiation via specific receptor-mediated signaling, and facilitates implantation through regulation of the maternal embryonic immune response. So in that respect, if we look at this, some anecdotal evidence, for example, for the importance of GM-CSF, we can see in the upper panel, again, looking at its expression, and in the lower panel, looking at its secretion. So production of GM-CSF within the fallopian tube and endometrium peaks during the early and mid-secretory phases of the menstrual cycle, respectively. And this is exactly around the time that fertilization and implantation occur in those two different sites. And interestingly, if you look at the levels of GM-CSF within the systemic circulation during pregnancy, you can see that in women, levels normally increase rapidly during the first trimester of pregnancy, though that increase does slow down during the second trimester. However, in contrast, GM-CSF barely rises above basal levels in women who have experienced recurrent miscarriage. And this, of course, suggests that a maternal environment that may be detrimental to embryogenesis and implantation due to the lack of GM-CSF within the maternal environment. And going back now 20 years ago, there were some basic science studies on the effect of GM-CSF in culture media, which showed in this left-hand panel and right-hand panels, you can see that human embryos attained higher cell numbers with an increased percentage of embryos developing to later stages of development. And in that central panel, you can see that these embryos also had significantly elevated glucose transport. And Also observed was suppression of stress response genes and lower rates of apoptosis. So in the presence of 2 nanograms per mil of GM-CSF, inhibition of apoptosis led to a highly significant increase of cell numbers within the inner cell mass, as you can see in that right-hand panel. The physiological effects of GM-CSF, therefore, show that it acts as a growth and survival factor, promoting embryogenesis, controlling apoptosis, stimulating metabolism, and reducing cell stress within the embryo. So presumably increasing the developmental competence of the embryo and its ability to implant. And we believe that this is achieved via embryonic signaling. So as I showed you, basic research on the role of GM-CSF in reproduction forms the rationale for adding it to culture media, and it provides the opportunity to investigate its potential clinical benefit. However, before you can use it clinically, you need some safety data required to prove its hopeful safety prior to clinical use. So, for example, in this study, human oocytes donated to research were randomly assigned to culture in the presence of 2 nanograms per mil of GM-CSF or to control medium devoid of GM-CSF. Now, to control for the effect of the paternal genome upon embryonic euploidy, all oocytes were inseminated using the same sperm donor. And to get a thorough study, most information as possible, all nuclei from all blastomeres in each day 3 embryo were assessed using fluorescence in situ hybridization. Now, there was no significant difference in fertilization rate and cleavage rate or normal development. But as you can see in this histogram, there was also no difference in the percentage of overall euploid, uniformly euploid, and mosaic euploid day 3 embryos, suggesting that GM-CSF could be safely added to culture medium. So to that end, this was the very first clinical study of GM-CSF supplemented culture media, and it was a multi-center, prospective, randomized, controlled, double-blinded clinical trial, which was conducted in 14 IVF centers in Denmark and Sweden, with well over 1,000 patients having their embryos randomly assigned to culture either in standard medium, which was embryo cyst from Origio, or embryo cyst containing 2 nanograms per mil of GM-CSF. The full study you can see on the left-hand histogram showed that addition of GM-CSF to the culture medium elicited a significant increase in the survival of transferred embryos from week 12 of pregnancy up until live birth. Furthermore, that same RCT found that culture medium containing GM-CSF was particularly efficacious in women who had experienced a previous miscarriage, as shown here in this subgroup analysis of 289 embryo transfer cycles. So based upon those results from the safety analysis and that initial multi-center RCT, both one-step and sequential media have since been developed, all of which contain 2 nanograms per mil of recombinant human GM-CSF. And that is actually well within the physiological range at which this potent cytokine exerts its effects. A subsequent retrospective study of 197 women with previous failed or IVF or ICSI cycles showed that although there was no significant difference in the clinical pregnancy rate, you can see there, albeit it was higher in embryos transferred following culture in EmbryoGen containing GM-CSF, there was nevertheless a significantly higher ongoing implantation rate at 7 and at 12 weeks of pregnancy. This retrospective data reported by the Center of Excellence at the Fertility Center in Hamburg showed that, as you might expect, the pregnancy rate per transfer in their patients whose embryos were cultured in their standard control media declined with increasing female age. However, in a much smaller cohort of patients, this age-dependent decline in pregnancy rate was actually reversed for embryos which were cultured in Embryogen, suggesting a possible benefit of GM-CSF in older patients. And this pilot study in New Zealand of the first 100 poor prognosis patients to be offered embryo culture with Embryogen at Repromed, which was reported at the CERT meeting in Auckland in 2017, showed that the average female age was 37, and these women had had a mean of 2.5 previous attempts prior to their Embryogen cycle, some experiencing pregnancy loss, but mainly experiencing implantation failure. But to control for variation between patients, they performed a subgroup analysis of 45 of those 100 patients who had undergone a previous cycle using Repromed standard media. And as you can see, as well as observing a higher proportion of blastocysts suitable for cryopreservation following culture with Embryogen, exposure to GM-CSF resulted in much higher rates of clinical pregnancy, fetal hearts, and live birth or ongoing pregnancy. And you can see this here in these histograms showing a doubling of the clinical pregnancy rate and almost a trebling of the fetal heart rate in those same patients. This longitudinal retrospective study compared 10 patients receiving donated oocytes that were inseminated and cultured using conventional media, which was cleavage and blastocysts from Origio. And this was followed by 15 patients receiving donated oocytes that were cultured using Embryogen and BlastGen. In this study, they observed an increased fertilization and pregnancy rate in those patients whose donated oocytes were cultured in the presence of GM-CSF, though this failed to reach significance for pregnancy rate. Now, of course, there may be other reproductive cytokines that could also be beneficial for culturing embryos in. So this triple-blind, parallel, randomized controlled trial was designed to see whether a cocktail of 2 nanograms per mil of GM-CSF plus 5 nanograms per mil of heparin-binding epidermal growth factor and leukemia inhibitory factor might indeed be beneficial to lab and clinical outcomes in 443 ICSI cycles. As you can see in this table, culture of embryos with the cytokine mixture significantly increased their primary outcome, which was the ongoing pregnancy rate. But it also significantly increased their secondary outcomes, including the live birth rate and cumulative live birth rate, while significantly reducing the rate of pregnancy loss. The so-called BlastGen study was a pilot randomized clinical trial comparing culture of embryos in the center's existing optimized culture system using cook media against culture of embryos in BlastGen. As can be seen in this table, there is no significant difference in fertilization and day 3 good quality embryo rates, though the latter are actually higher in the BlastGen group. However, there was a significant reduction in blastocyst formation rate to such an extent that these embryos metaphorically fell off a cliff, though this was insufficient to result in any significant difference in live birth rate. Now, possible explanations for such an unexpected result include the fact that more patients were treated with ICSI and had failed fertilization in the BlastGen group, which of course cannot be attributed to any subsequent difference in embryo culture media. However, a more plausible explanation is that the center's existing culture system, which had been optimized for their cook media, was actually unsuitable for the BlastGen media, since the blastocyst formation rate was well below what would be expected based upon Vienna consensus key performance indicators for lab competency. Now, this is a retrospective case-controlled study of severe poor prognosis patients. These are 49 patients who were identified with a history of developmental arrest of their embryos in standard culture media. Now, they defined developmental arrest as a failure to reach embryo transfer following 2 consecutive cycles with at least 6 oocytes retrieved and at least 5 fertilized. However, the inclusion and exclusion criteria narrowed this down to just 39 patients. So they found a control group with tubal factor infertility, which they matched from their database in a 2-to-1 ratio. And that control group were cultured using SAGE one-step medium from Origio. The embryos of the developmental arrest group were cultured in Embryogene. And as you can see in this table, GM-CSF resulted in rescue of these poor prognosis patients because there was no significant difference now in outcomes between these 2 groups. So in summary, we know that the etiology of infertility can affect treatment prognosis. And in this respect, we need to remember that approximately 20% of patients accessing assisted reproduction treatment have a poor prognosis, presenting as repeated implantation failure or recurrent miscarriage, which are most likely due to embryonic and/or endometrial factors. We also know that single-step and sequential media perform equally well, and that media containing cytokines appear to offer great promise, especially for poor prognosis patients. However, we still require sufficiently powered, properly controlled, randomized controlled trials of culture media. So here are the reference to the work that I cited in this presentation. And I'd like to thank you all for your attention, and I'd be very happy to answer any questions if time permits.
Are there any questions to Dr. Steve? If not, I would like to ask one thing. I have used the GM-CSF, the Embryogene and the BlastGene. In that way, do you think it's better? Where is it used? Its use can be much more optimized as a culture media or as a media of transfer?
Yes, that's a very, very good question, Priya. And I thought you were going to ask me whether it would be better to use it up till day 3 or better to use it after day 3, but I'll take all 3 of those. Essentially, we know that what happens early in embryogenesis very much dictates what happens later. My suspicion is that you'll see the greatest benefit when you use sophisticated media containing cytokines such as GM-CSF within early culture. And in fact, there have been some studies showing that even if you culture immature oocytes in media containing GM-CSF, you see a beneficial effect later on with the use of in vitro maturation and subsequent fertilization and development of those in vitro matured oocytes. So the suggestion seems to be that the earlier you use it, the better. Now, presumably, it still has a beneficial effect later in embryo development from day 3 to the blastocyst stage. And whether it actually has a benefit as a transfer media, I think is far less clear. It's a bit like high hyaluronan in this respect. Many culture media, including in fact the media containing GM-CSF, contain high hyaluronan. Now, it's probably far more likely that those factors within the culture media confer a benefit to the embryo during that longer period of culture than they would during that very short period of transfer, when presumably the transfer media is only like 10 to 20 microliters or whatever. That soon gets dissipated, and any possible benefit of it maybe doesn't get sustained for very long. So that's my belief anyway, and I think the data supports that, and I haven't seen any great amount of data. I mean, again, one study with frozen embryo transfer again suggesting that transfer in media containing GM-CSF may be beneficial, but that was only in a presentation at a conference. So I hope that helped answer your question.
Yes, definitely, because I had used on both, like used as a media of transfer and as a culture, and both for some patients. So yeah, it is an interesting suggestion to have this one, but just what's limiting is the cost of the media, actually.
Yep, I agree with you entirely. So batch your patients, split it between several patients. You're only using microliter volumes for culture, so you can batch your patients and save costs that way. And yeah, my money would be on using it. The earlier you use it, the more benefit you'll see. Yeah.
Thank you, Steve. Thank you so much. Organizers,
Welcome.
do we have any questions from the audience?
No, ma'am.
No, thank you. That means that we would have to move over to the next session. And thank you so much, Steve, for being here and for delivering this wonderful talk for us. Always
My
a pleasure to have you on ACE. Thank you so much.
Thank you again.
So we would move on to our next presentation by Colin Lynch on biopsy, PGT relating to the healthy life. Could I have her? Yes, please. Dr. Lynch is a training and scientific manager at Cooper Surgical Fertility Solutions with a BSc in genetics and MSc in medical genetics, completed at Glasgow, and a PhD in genetics completed at University of Kent. She provides professional education, training for all levels and disciplines working in aortic clinics, including hands-on workshops. She's been in the field for about 17 years, including as a UK state-registered clinical scientist in embryology, PGT and lab manager, PGT quality manager to the ISO 15189. Her research interests include optimization of embryology procedures and clinical outcomes in PGT. Over to you, Dr. Lynch. You're on mute.
Thank you very much for the introduction, and thank you very much to the organisers for inviting me to speak to you all today. I was asked to speak about biopsy and PGT, and in keeping with the theme of your whole conference, to relate it to the healthy life. So before I sort of start, just to go through what we're going to speak about today, after my introduction, I want to talk about some of the stages in terms of PGT and biopsy, where we may or may not be impacting our clinical outcomes. But in terms of introduction, I just want to go a step backwards again to remind ourselves why we're performing PGT and why we're performing embryo biopsy. So taking it right back to the beginning, we're obviously all made up of trillions of tiny cells. In pre-implantation genetic testing, we're concerned with the contents of the nucleus, where all of our genetic information is stored. And it's the chromosomes within the nucleus that contain our hereditary material. Most people will have 46 chromosomes, but some of us have 45, some of us have 47. And the chromosomes are actually packages of tightly wound DNA. And you can see that represented, as we normally do, as the double helix, where we have what looks like steps on the ladders representing the nucleotides or base pairs. And those are either A's, T's, G's, or C's, which is the basis of our genetic code. And it's important to realize DNA doesn't actually do anything. It just stores information. So this sequence of A's, T's, G's, and C's is not unlike the binary code in computers of zeros and ones, which spells out instructions. So our DNA is almost like our hard drive. And this is basically storing the instructions to build proteins. And it's then proteins that do the actual work to maintain and sustain life. So pre-implantation genetic testing today is largely split up into 3 different treatments. PGT-A, pre-implantation genetic testing for aneuploidy, which was previously called PGS and is sometimes also called CCS, or comprehensive chromosome screening. This is a test where we're screening for chromosome abnormalities, so at the level of the whole chromosome, or large deletions or duplications. It's an option for all IVF patients. The idea is to try and improve success rates by selecting the most viable embryo for transfer. And it doesn't require a personalized test preparation for the patients. We've also got PGT-SR, pre-implantation genetic testing for structural rearrangements. And this is testing for inherited chromosome rearrangements. So when one of our patients, one of the parents is a carrier for a translocation, an inversion, or a complex chromosome rearrangement. And in this case, what we're doing is we're reducing the risk of pregnancy loss for these patients and reducing the risk of having a child with a developmental disorder caused by either a duplication or a deletion of chromosome material. And it's important when we think about PGT-A and PGT-SR about the number of genes that are involved here. So in PGT-M, pre-implantation genetic testing for monogenic disease or single gene disorders, we're dealing with the change of maybe one base pair in a sequence of DNA, whereas with PGT-A and PGT-SR, we're dealing at the level of the chromosome. Chromosome 1, the largest of the chromosomes, has over 3,000 genes. Chromosome 21 has over 400. And then the Y chromosome has unfortunately only 200 genes compared with 1,400 on the X chromosome. And that's why the gain or loss of parts of a chromosome or whole chromosomes are very important because of the amount of dysfunction that is created, which is normally non-viable. PGT-M, single gene disorders, as I said, is screening for a specific single gene disorder that we know a couple are at risk for. Either a parent may be a carrier or may be affected by the genetic condition. And so here we're reducing the risk of genetic disease. And for PGT-SR and PGT-M, there's normally some type of workup that is required, whether in the case of PGT-SR, it may be as simple as looking at the parental karyotypes and making sure that we're able to detect the smallest potential imbalance. Whereas with PGT-M, there's normally a much more complicated personalized test prep and design. And today, this is what most PGT cycles will look like, where we're performing IVF or ICSI, followed by embryo biopsy at the blastocyst stage, which may be on day 5, day 6, or day 7. In the embryology lab, we then vitrify our embryos while we're awaiting the results. And the sample normally goes off to an external centralized pre-implantation laboratory, but that is basically what they specialize in doing, just testing trophectoderm samples for PGT using either next generation sequencing or carrier mapping or some other type of SNP analysis. And the genetics laboratories will generally then send the report back to the IVF clinics, who are hoping then to identify, warm and transfer, if available, genetically suitable embryos for transfer. And then ideally, any additional genetically suitable embryos can remain frozen for future use. So in terms, in way of introduction of trophectoderm biopsy itself, the feasibility of biopsying at the trophectoderm stage was demonstrated back in 1990, where the blastocysts were mechanically hatched and had cells removed and remained intact in culture after 24 hours. But it was a number of years later, mainly due to catching up in the lab in terms of blastocyst culture, that we had the first live births following blastocyst biopsy and PGT analysis in 2002. And out of 15 patient cycles and 30 embryos analysed, they ended up with one healthy male live birth. Important to state is that we don't see any increase in the risk of adverse perinatal outcomes in terms of congenital abnormalities, preterm birth, or low birth weights following PGT with trophectoderm biopsy when we compare it with autologous IVF. So if the treatment of PGT and biopsy should technically not impair our patients in terms of outcomes and healthy live births compared to similar groups, is there anything that we're doing in the lab that positively or negatively impacts on our patients, on any children born, or in the clinical outcomes? And so I just want to talk about some of the steps that are commonly discussed when labs are looking to optimize their biopsy practice. So starting off with assisted hatching. And this is probably one of the most variable practices that we see when we look at different laboratories performing pre-implantation genetic testing with trophectoderm biopsy. And this is because there's a number of different ways of performing hatching. It can be done mechanically, it can be done chemically, or it can be done using the laser. Then it may be done at different stages in embryo development, either at day 3, at the morula stage, on the day of biopsy, where it's performed on the morning of day 5, and then the embryos are returned to culture until they hatch, or there may be simultaneous hatching of the zona and cell retrieval. So historically, hatching would always have been performed on day 3 of development because we performed blastomere biopsy. And so this continued when most laboratories moved to trophectoderm biopsy. Many groups still use this approach, but there are a number of concerns. The first being that the zona remains at the same thickness as day 3 or day 4 in development. So we have cells herniating from the embryo as it develops into a blastocyst, rather than stretching and thinning the zona, which may impede natural hatching and implantation. Because the approach encourages herniation of the trophectoderm from the blastocyst earlier in development, there is a concern that they may encourage some people to perform biopsy too early, when there's fewer cells in the trophectoderm and have a greater impact on implantation. And obviously, if we're going to perform assisted hatching at any other time than at the time of biopsy, there's going to be a disturbance to the culture system. However, there is very limited data available comparing the timing of assisted hatching. And if the main information we have is where people have switched from day 3 or morula hatching to looking at doing the biopsy and the hatching simultaneously. We have some studies that have shown absolutely no differences in survival, post-warming, implantation rate, clinical pregnancy rates, or miscarriage rates. And only one study which actually showed improved survival rates post-warming and increased implantation rates and live birth rates when doing the 2 procedures simultaneously. But it was important to note in that study that it wasn't very well controlled. And at the same time, they also switched to removing a quarter of the zona post-warming. So it's very difficult to say what actually contributed to the increase in the implantation rate and live birth rate. Looking at the biopsy technique in itself, again, unfortunately, we have limited and contradictory information comparing our biopsy techniques. There's a study that has demonstrated no impact to DNA profiles when up to 5 shots of the laser were used in the range commonly used to perform trophectoderm biopsy. This was performed using H1 human embryonic stem cells, which are probably a lot more robust than the trophectoderm cells that we would use in pre-implantation genetic testing. The two main methods which are currently used are what we call laser and stretch, where we basically aspirate and stretch the trophectoderm while firing the laser until the cells detach. And then another called laser and flick, where we only use the laser for 1 to 3 pulses to create a weakness in the trophectoderm, and then essentially perform a mechanical biopsy by flicking the biopsy pipette across the opening of the holding pipette. One study has demonstrated no differences in the two approaches. We've got a study that compared laser and flick with mechanical biopsy, so just the flick, and the latter group demonstrated significantly better survival rates on warming post-vitrification. But the International Society for Pre-Implantation Diagnosis, PGDIS, they basically published a position statement on chromosome mosaicism and pre-implantation aneuploidy testing at the blastocyst stage. And they have stated that if the biopsy is facilitated using a laser, the identified contact points should be minimal and preferably at cell junctions. And the overly aggressive use of the laser may result in cell damage and partial destruction of cellular DNA. And this is really where the main issue comes in terms of the biopsy technique, which is if a biopsy is done badly or is done in a way that creates any cellular lysis, we then get a messy lysing sample that goes to the genetics lab, which has an increased risk of either not having a result, having an inconclusive result, or in the absence of algorithmic data calling, the potential for scientists to overcall low-level mosaicism if they have messy data to analyze. Moving on to think about blastocyst quality. Again, you may be surprised for me to say there's contradictory information on the impact of morphology, but it is generally acknowledged that poorer quality blastocysts can be euploid, and they do result in clinical pregnancy and live birth at times. Some studies have shown that the morphological quality of the blastocyst doesn't impact on whether we get a result from the embryo or not. So we're as likely to get a result from a poor quality blastocyst as a top quality blastocyst. We're seeing an increase in the use of biopsy at day 7 for slower developing embryos. And a number of studies have shown that these embryos have lower euploidy rates, but similar sustained implantation rates to day 5 and day 6 blastocysts. It's important to note, though, that there's no consensus in terms of how we culture the blastocysts to day 7, and whether this is just in the same media, the same one-step media, or whether it requires the media to be refreshed. We've also got papers that suggest that survival post-warming may be lower in poor quality blastocysts and day 7 blastocysts. And the live birth rate for poor quality blastocysts has generally been reported as around the 10% mark, along with a lower euploidy rate and a higher miscarriage rate. One of the areas where it seems to be most important is in terms of the number of cells that we take at biopsy. And we can see from this very nice study from about 5 years ago now, that if we look at the implantation rate compared with the number of cells that we take, when we have a grade A trophectoderm, it seems like we can almost take as many cells as we want without impacting the implantation rate. But grade B and grade C trophectoderm cells are much more impacted by cell removal. And this is a much more recent study that has come out, although it only covers 208 embryo transfers, unfortunately. But we can see here, plotted out, the sustained implantation per euploid blastocyst, comparing the day 5 good quality blastocysts in green, fair quality in yellow, poor quality in red, and then the day 6 embryos in grey. And we can see the sustained implantation by maternal age from 33 through to 39. And we can see that for the day 5 blastocysts, we do seem to have that sort of negation of the age effect, whereas with the day 6 blastocysts, we seem to have a fall in implantation rates. It's always important when we look at data like this with, implantation rates of, even 40% up to 80%, that we remember that this is per euploid embryo. So all of this information is contingent on the fact that a euploid embryo is identified to begin with. But I obviously mentioned cell number, and this is something that is very important. And when people moved from day 3 biopsy to blastocyst biopsy or trophectoderm biopsy, there were papers that were initially published saying that trophectoderm biopsy didn't have any impact on implantation. And I certainly wouldn't agree with that statement, insofar as everything that we do in the lab has some type of effect on implantation. So the number of trophectoderm cells taken at biopsy may be vital. And we've especially got to remember that the trophectoderm function is increasingly being recognised as vital to implantation and sustained pregnancy, compared to that of the inner cell mass. When we look at cell numbers, the cell numbers that are required do tend to be dependent on the methodology of testing that you're using. In essence, we can get a sample that's just one cell and still get a result from it with the majority of testing platforms. But we've got one study with fish analysis that showed that the diagnostic efficiency was maximized at around 6 cells. We've got a study using quantitative PCR with the diagnostic efficiency maximized when we had a minimum of 8 cells biopsied. And then a really, really interesting study using array CGH and SNP arrays, showing biopsying an average of 10 cells negatively affects embryo implantation when compared to biopsying an average of 5 cells. But it didn't increase the miscarriage rate at just implantation. And here we can see from the qPCR paper, they were able to establish a cell number from the DNA content and look at 4 different groupings, with the first group being up to 5 cells and the final group being 15 to 20 cells. This wasn't stratified by embryo grade, but we can see here in terms of positive pregnancy test, implantation rate and ongoing pregnancy, in each indicator, we're getting poorer outcomes the more cells that we take from the trophectoderm. Finally, just to speak a little bit about vitrification of biopsied embryos. When we moved to doing biopsy at the trophectoderm stage, many people wanted to get the results within about 24 hours, so that if they did the biopsy on day 5, they could transfer on day 6. But it's important to notice that in terms of the data that's been published, vitrification and frozen embryo replacement in PGT doesn't negatively impact clinical outcomes. And in some situations, it actually results in improvements. And this is again because we're going to transfer the embryo as a day 5 embryo on the frozen cycle, rather than waiting to transfer the embryo on day 6, contingent on when we get the results back. But the main concern attached to frozen embryo transfer in PGT cycles is the loss of euploid or genetically suitable embryos. And again, it's important to note that there's no evidence that the loss rates are increased in biopsied embryos. So if you're looking to benchmark your vitrification survival rates post-biopsy, they should be exactly the same as your normal patients. The main discussion is when we should actually vitrify the blastocysts. Again, data is limited and seemingly contradictory. Survival rates are always reported in line with the non-biopsy blastocysts and exceed what the ESHRE competency values are. But generally, the publications that are out there generally support vitrifying post-biopsy in line with what your validated laboratory procedure is. So in labs that normally collapse before vitrifying, vitrification can be performed almost immediately after biopsy. And papers from groups that do this have excellent results. Whereas if you vitrify without collapsing, post-biopsy, you need to allow your embryos adequate time for recovery and culture after biopsy. And this is what we see in terms of publications. The centres that normally collapse before vitrifying get the best outcomes when they vitrify very quickly, whereas centres who've published who don't collapse, they get their best outcomes when they allow this time for recovery in culture after biopsy. So just to conclude for you now, it's important to realise PGT is a valuable tool that's available to help patients. With PGT-SR and PGT-M, obviously, we're dealing with testing for hereditary genetic disease or chromosome disease. PGT-A has been shown to mitigate age-related miscarriage. It also has the power to reduce emotional trauma and increase chances of successful live birth per cycle started. But it's not a magic bullet, and it needs to be paired with high quality embryology. So in terms of offering PGT, you need a high blastocyst development rate, an optimized culture system, highly trained and experienced biopsy practitioners, and an excellent vitrification program, or PGT outcomes will be negatively impacted. But my final sort of conclusion is much the same as my colleague Steve's was that really we need a lot more better designed studies which are controlled and more data analysis to define if there are any best practices for best outcomes. Okay, thank you very much.
Thank you so much for covering each and every aspect that we needed to have, like and giving us evidence on the same. It was thoroughly enjoyable to listen to that, and I'm sure we have so many take-homes and for all the practitioners and the beginners, as everything that's needed was there in your presentation. Thank you so much. Are there any questions from the audience to Dr. Lynch?
No, ma'am.
Okay, if none, I would just like to ask one. When we culture the expanded blastocyst after biopsy, that is without collapsing the blastocyst prior to the biopsy, but anyways, while doing the biopsy, it automatically collapses, doesn't it? So in that case, when we want to vitrify, what you might think might be the ideal time to leave it in culture? Is it until we see a re-expansion, or maybe for about 2 hours or half an hour? What do you think? Can you guide us on that?
So I think the main thing is that we've got papers out there that say you will get the best outcomes if you vitrify very quickly within sort of 30 minutes when the embryos are still collapsed. But there are other papers that say you will get the best outcome by allowing 3 to 4 hours for recovery so that the embryo re-expands. And what you see when you look at these papers in detail is the people that say we get the best outcomes by vitrifying really quickly are the people that normally collapse blastocysts before they vitrify them. Whereas the people who are publishing the papers that say allow the embryos to recover and to re-expand are the people who don't collapse and so are more used to vitrifying embryos when they're at that expanded stage without the collapse. And so I think the data at the minute really just says, you know, use your normal vitrification protocol. So if you normally collapse, vitrify them quite quickly. If you don't normally collapse, allow them to re-expand. And if you try and do something that is not the validated process in your lab, like suddenly vitrifying them when they're collapsed, when that's not what you normally do, then you might end up with poorer outcomes than you do for your standard blastocysts. In terms of if you don't collapse and you're looking for your embryos to re-expand, you really want to see the embryo more or less fully re-expand. And the studies that have looked at this in terms of vitrification and biopsy have basically said that the majority of your embryos should have re-expanded within 3 hours. If your embryo hasn't re-expanded within sort of 3 to 4 hours, there really isn't much benefit to leaving it much longer. You could have a go at vitrifying it while it is still collapsed. It's not a 0% chance of being a viable embryo, but in these studies we know that the embryos that don't re-expand within that sort of 3, maximum 4 hours post biopsy is generally not a good prognostic factor for the embryo anyway.
Thank you so much for clearing my doubt as well. In view of the time, we might have to move into the oration right now. So thank you so much for the lecture and for giving us all the evidence.
Sorry to interrupt, ma'am. Professor Rashida's talk was skipped. So,
okay,
yeah.
now do we have it now? Because
Yes,
11 and 12 is isn't it the oration? Do we come back after the oration, or how does it work?
Ma'am, oration will be going on in Hall A.
Huh? And we continue here?
Yeah.
Is it?
Yes, ma'am.
Because yesterday we stopped the session for the oration.
Okay, ma'am. Let me check.
I think go for next session because as time is over.
No, ma'am, just a second. We just clear it. We don't want to miss listening to you. So only issue is like, ma'am, in the oration, after an hour, we'll continue with your talk and then go on to the next one, ma'am. Just because it's the oration, we wish to have all the participants enjoy the oration, because it's you know, people who are talking today are like the people who have worked closely with Dr. Subhash Mukhopadhyay. So he's a great pride for us. So
I know.
So have you checked?
Yes, finally I could manage my everything.
Okay.
Can you
that's
see my
great, ma'am.
slide? Can you see my slide?
Yes, ma'am. We are able to see the slide. So just a moment.
I can manage camera.
And that's great, ma'am. So 1 second, ma'am.
Okay.
The conference team, have you checked with the organizers on whether to have the session now?
Saroj ma'am told us that she'll be presenting the last.
It is now. It is 11:36. When is the oration?
Now, ma'am, it starts at 11. I'll just check with Saroj. Just a second.
Okay, I think if there is time afterwards, I can present. Whole day I am in here, no problem.
So do we wait for Saroj to come to introduce the speaker, or what do we do?
We have already introduced her.
Okay. So
Yes,
madam is going to present now, or are we shifting to the oration hall and coming back here later?
As you like, no problem.
No, ma'am, I'm just asking the organizers so that they can let us know what's happening.
Let me check.
Sure, please call Dr. Saroj or Dr. Parag and Check it out, please. We shall wait for you.
I think you can go for oration. Then afterwards you come back.
That's so nice of you, ma'am.
I will also join in this session, oration.
Yes, ma'am, it's in hall 1.
Yeah, I know. I think Dr. Sudarshan Dostidar will present something, and he presented it in another your conference. Same presentation I heard it.
Okay, ma'am. We'll be after the oration. We will be starting the session.
Sure. Thank you so much.
Yeah.
Ma'am, we'll just break for the oration. We'll come back, ma'am.
Okay.
Thank you, ma'am.
And you'll call back. You'll give a
We'll
call.
come back to the same hall for your presentation.
Ma'am, I'll call you.
Yeah, you'll call me. Thank you.
Yeah. Hello, Dr. Manisha, Dr. Luna.
Hello. The term was not coined at that time, IUI.
Hello.
Here I'd like to mention that wonderful junior doctors, Dr. Arup
मैम
Maji,
आप थोड़ा सा उसका वॉल्यूम टर्न डाउन कर देंगे क्या?
late Dr. ma'am. S.M. I was in Goswami, audition. I used to call him Partho. Yeah. Is it okay? Can you hear me now?
Yes, ma'am. So there is an update. Dr. Gaurav's talk will be on second, and Dr. Sudesh's talk will be on first.
Fine. It's okay with me.
Yeah, that's what. Yeah.
Okay, fine. Are you gonna show the PPT introductory slides?
Yes, ma'am. I'll display the introductory slide,
Perfect.
and Dr. Luna will be the other chairperson.
I know. So if she wants, she can introduce him. Otherwise, I'll be doing.
Yeah.
Chal, thank you. And I think session is late by half an hour, so we can peacefully attend the audition.
Yeah. Yes, ma'am. We will start after the audition.
Perfect. I'm here only. Thank you so much.
Hello, Sudesh sir.
Hello, hi.
Hi, sir.
Was
So
this
you,
Himanshu?
yes.
Yeah, hi, Himanshu.
Hi,
Doing
sir.
a great job.
Yeah.
Yeah.
So first you will be presenting. Are you
Okay.
sharing the slides or shall I?
I will share it. Can I just share, check it now?
Yeah, check. You can check, sir. Yeah.
Yeah, just 1 second. Yeah, you can see it. Hello.
Yes, sir. We can see it.
Yeah. So should I now, what should I do? Should I leave it like this or should I stop sharing and then?
No, sir. Stop sharing. First, I will
Just one
share the
second.
chairperson CV. Then.
Why I can't raise my mouse?
Yeah.
What happened to my mouse? Yeah. So tell me then. So I am all set.
Okay, sir. Noted.
Thank you.
Thank you. Dr. Rashmi, ma'am. Rashmi, ma'am, are you there? No. Sir, you can stop share.
Yeah, 1 sec.
Yeah,
Just give me 1 minute. I think
no.
it's still there, 1 sec.
Yeah.
Brown, the oocyte was aspirated from a natural cycle.
Just 1 sec. I'll just do it.
Where that natural cycle made it very difficult, as we know, to just get that single oocyte, get an embryo and a pregnancy. And he had attempted stimulation, but stimulation had not led to pregnancy because it led to the shortening of the luteal phase, and which means that women had to be given progesterone injections, which are intramuscular pain injections.
Hi, sir. Manisha here. Good.
Well, hi, how are you?
All good. And I feel totally privileged introducing you today.
Our voice is not going there, no?
Oh, hopefully.
I don't know. Because some talk is going on.
Yes. I see you then. Bye, sir.
Bye.
That is laparoscopically, and that is why they gestation.
this chamber, I can remember Dr. Even Parikh, I have seen the photograph. I was on the only wall chamber. And Dr. Even Parikh, it was in 1985, proposed for the ISAR formation with that chamber. I have no idea. Dr. Isik has actually and he has proposed Dr. Chakraborty's chamber. I was the living witness at that time. And another important incident I will say, I should not.
I thank all our chairpersons, Dr. Srinivas, Dr.
I think we can start the lectures here.
Okay,
Dr.
ma'am.
We can start.
Shakir?
Who's the chairperson?
Ma'am, wait, ma'am. First, we have to start.
Ashi, please take over.
Yes, Himanshu.
Please go live.
Would have to proceed.
Okay, give me 1 minute.
Yeah.
Thank you.
Shakir, are we ready?
Yeah, just a minute. Yeah, we're ready.
Ma'am, start.
Welcome back to Hall B. We'll commence with the next session titled Improvement in
Excuse me, sorry to interrupt you. Give me a minute. Is there an error? Please allow me a few minutes.
Hi, Dr. Sudesh.
Hi, Dr. Gaurav. How are you? From the lab, even Sundays, your voice is not going anywhere, no?
नहीं अभी तो काम खत्म हो गया.
Okay.
So yeah, Sunday.
Even Sundays, I have to rush for the cases only now.
Yeah.
There was some problem. Otherwise, there was no case. But
It was yesterday also we worked.
But as an embryologist, I think we can't have any excuses. We have to work.
Both days gone.
I think that's Professor Luna, I think. Hi, Luna.
Yes. Hello. Hi, Sudesh.
Long time. How are you?
Oh, yes, I'm fine after a long time.
Great to see you.
And,
happy that you are chairing my session.
So the thing is that the man who taught me ICSI, I am chairing the session for him.
Oh, lovely.
Can we start, Dr. Sudesh?
Yeah, please. I am ready.
Late already.
Yeah.
Yes, we're all ready.
Hello, sir. Hello.
Please go on. We are live.
Hi.
Rashi, ma'am, start.
So welcome back to session 5, titled Improvement in Fertilization, When and How. It's my honor to call upon and introduce the chairpersons of this session, Professor Luna Samantha. Can I have the CV slide, please? Professor Luna Samantha is part of the Department of Zoology and Center of Excellence in Environment and Public Health at Ravenshaw University, Cuttack, Odisha. She specializes in redox regulation and omics biomarkers of human reproduction with special reference to paternal factors in recurrent pregnancy loss and varicocele. She's also visiting faculty at several reputed universities and is the receiver of several awards. Welcome, ma'am.
Thank you. Thank you very much. It's a pleasure to be here.
Can I introduce the next chairperson, Dr. Manisha Vajpayee? Dr. Manisha Vajpayee is currently the director at Embryology and Research, Pacific IVF Center, Pacific University, Udaipur. She was the ex-scientist at Department of Molecular and Cytogenetics in New Delhi, and she specializes in PGT-PGS, metagenomics, and genetics in reproductive medicine. She also is heading 3 research projects granted by Department of Science and Technology, Government of Rajasthan, and is again the receiver of several awards and accolades. Welcome, ma'am, and over to you both for the session.
Thank you very much. We are already running late, almost like more than half an hour. So it's a pleasure to be in this ACE meeting. It would have been much better if you would have met in physically. Physical mode is definitely not visible in near future. But anyway, we will meet again, and we are waiting almost for a year for this Calcutta ACE, right? So actually, being nearby to Calcutta, I was always expecting when this opportunity will come and we can meet together. So with this word, let me first ask the organizers to please give me the CV of Dr. Sudesh Kamath. So this is a good old friend. I came to know him in 2000 when Dr. P.N. Chakraborty was invited for a talk at Bhubaneswar, and Dr. Sujata Kar, with whom usually I work with for research collaboration, they invited Sudesh for the first IVF cycle in Bhubaneswar. So this was the first guy who taught me ICSI there and there. I was working with only animal embryos and eggs, oocytes and spermatozoa. So he is the man who taught me. And it is always a pleasure to introduce your good old friend in a particular platform like this. So Sudesh has almost 28 years of experience in human embryology, and the first chairman of Embryology ISAR from 2018 to 20. And he is the recipient of ISAR Lifetime Achievement Award for Embryology, although he is quite young to achieve a lifetime award. When we talk about lifetime award, usually we think of quite senior persons, elderly ones, and of course he deserves it. A recipient of ET Health World All Indian National Embryology Icon Award. This is a gold award for him. And he's the first ICSI baby in India, Nepal, Rwanda, Africa is credited for. And the second assisted hatching baby in India. And the first imprisoned single sperm baby in India using sperm VD injected more than 3 lakh oocytes till date. But I think he has much more to be spoken about. And above all, he's a noble soul and is a very good friend and is really helping one whenever you need him. He will be the first one to attend you. So with these words, I welcome Sudesh to present his talk on 100% sperm abnormality and what the expectations are from this type of parents. So this is over to you.
Thank you, Dr. Luna, for the wonderful introduction. Great to have you, Dr. Manisha, as chairperson. I can start my sharing the screen. Yeah. And before I begin my presentation, I would like to congratulate, people who have put in so much efforts. Our good friends Saroj, Parag, the organizing chairpersons, Dr. Gautam, Dr. Ratna, and of course, our ACE president, Ved Prakash. So I'll begin my talk. It's a simple talk. It is about 100% abnormal sperm morphology. Is there any hope for patient? I think before 1992, the only option, if it is 100% abnormal sperm, was donor sperm. But in 1992, things changed with the introduction of ICSI. So before I go into all that, I'll just talk briefly about our friend here, the sperm, his characteristics, his morphology. He is a very important person. He is the male reproductive cell, the male gamete. He is haploid, he has 23 chromosomes. His length of the head is around 4.5 to 5 micrometers. Width is around 3 to 3.5 microns. Tail is 45 microns long. Thanks to his tail, he is motile. He is able to reach the oocyte. He is able to fertilize the egg. And it is because of this, we can produce a new offspring. Now it looked very simple, that guy just a head and a tail. But if you see a cross section of the sperm, it is a very complex structure. Again, it's got a head, a tail piece. The head has the nuclear material, the DNA. It is covered with acrosome that has all the enzymes which the sperm needs to go through the complex layers of cumulus, through the zona pellucida. It has got, my mouse is not working. It has got mitochondria, the powerhouse of the cell, and the tail has axial filaments that helps the sperm to move ahead. If you see, we have now come to the 6th edition of WHO classification. You see sperm count, mostly there isn't much difference from 1987 to 2020, the 6th edition. There is just very few minor difference. It was 20 million was the count. Now it has come to 15. Motility was around 50. Now it is around 40. But if you notice morphology, there is a big difference. Earlier, it was like 80% had to be normal. Then it came down to 50, 30. And in 1999, it was 14%. Finally, in 2010, and the latest, now the morphology, even if you're just 4% normal sperm, that means the person has normal morphology, taking into account that other parameters are normal. So even a person who has 96% abnormal morphology is capable of fertilization without even help of ART techniques. Now, what is the importance of a normal sperm morphology? When you see a normal sperm, it is oval shaped, it will have an intact midpiece, uncoiled single tail. Most important is it will be able to move rapidly in a straight line. It can go towards the oocyte rapidly. And another important thing is it will contain healthy genetic information, which is very, very important. Otherwise, if you have abnormal sperm, either there may be more or less chromosomes, which are all causes of aneuploidy. Now, most of the centers have been following this Kruger-Strict criteria. If the normal sperm morphology is around 14%, then the probability of fertility is good. If it falls between 4 to 14%, the fertility is slightly decreased. And if it is below 4, say 0 to 3%, it is extremely impaired. There's just a picture of the different defects and all what we see, the normal sperm. Here we have abnormalities like head, the tail defect, neck, midpiece defects. All this you will find even in normal males, those who don't have any infertility problems. Now the head defects, your defects like in the shape of the head, the size of the head, like if you have small head, there'll be less chromosomes in there. These have all been found out in where you have large head, giant head, the number of chromosomes will be in excess. Suppose it's a very tiny pinhead, there may not even be any genetic material. So all these are defects. We also have defects like acrosome and all, which is absent, which plays a very important role to reach because without the acrosome reaction, there won't be any fertilization. Then we have tail defects. With the tail defect, there is no way the sperm can reach the oocyte. If it is non-motile, they can't move. And midpiece defects also plays a role, important role if you have bent neck or thick midpiece. Normally in vivo or in vitro, this is the acrosome reaction which happens. The sperm will go to the oocyte, will bind to it. Then there are acrosome reaction happening. And finally, the nuclear material is deposited in the ooplasm. Now, oocyte also, if you know, there is a natural selection. It will allow only a normal sperm to enter. So what about this abnormal sperm? How will they enter? It is not possible normally in IVF or in vivo. But thanks to this procedure, ICSI, where we take the sperm and we physically inject it inside, we force it actually into the oocyte. And with this procedure, with ICSI, things have changed. You can now, any sperm can fertilize an egg because there's a different mechanism which works here. You just need an oocyte activating factor. You don't need acrosome reaction for fertilization to occur. Sometimes you find non-motile sperm, but the morphology looks good. So can you select them? The thing is, they can be live sperm also. There are cases like immotile cilia syndrome. It will be 100% non-motile sperm. They will have normal morphology. The head will be all normal. You have tail defects, short tails and all. Or even in TISA, you find normally only non-motile sperm. So all these you can use. You can use techniques like you can either use theophylline or you can use HOS. But all this we can use and we can get fertilization. Only necrospermia is where you will not find fertilization because the sperms are dead. We have done cases, where we have even taken sperm from the testes, but some cases we did not find. We found even those sperms were all dead, and the only option was maybe go for some donor sperm. Another thing to know is now normal sperm. Even when we are doing ICSI, the normal sperm. What if it has got high DNA fragmentation? Say DFI is more than 30%. How do we know? Okay, we have done a staining, okay, 30%. But when you're selecting the sperm, how do you know which sperm to select? For all you know, you may end up picking a sperm which has high DNA fragmentation. So now we have got certain techniques, like sperm pressure using density gradient, where there are some reports which say that will, decrease the DFI. The sperms which we get, we'll get better sperm. Microfluidics is another recent development. Of course, we also have repair mechanism. When you do ICSI, the oocyte can repair if there is some DNA fragmentation in the sperm. Other options, we can use testicular sperm, or also we can use selected techniques like IMSI-PIXI. We have been doing a lot of IMSI for cases with high DNA fragmentation. There is one case you will see, there's a lot of vacuoles. So where there is vacuole, there is some papers which say wherever there is a vacuole, those sperms are DNA fragmented. So we magnify the sperm 7,200 times. We avoid these sperms which are vacuoles, and then we pick up a normal sperm. This is one very interesting paper. It is cited a lot. Here in this study, there were around 24 men. Of course, the number is less, where the count, it was total 0 normal forms. And after 2.5 years follow-up, 29.2% of these people in this study, they were able to have a pregnancy without ART techniques on their own. So there is also hope, patient with 100% abnormal form can have a natural conception. Another study where they have compared, ICSI was done in a group with 0% normal forms, and in other group it was more than 1% normal form. And they did not find any difference in fertilization rates, clinical pregnancy rates, or live birth rates, whether you injected the abnormal sperm or a normal sperm. These are normally in varicose, you will find this tapering head and a lot. Earlier, when it was, I think, 1999, we were following that WHO, most of the morphology and all, 14% and also many of them were abnormal. But today it is just 4%, and this you'll always find some normal sperm. So many of the urologists now, they have even stopped doing varicocele surgery. This is one thing what we have been doing a lot, micro TISA. These are cases where they have earlier previously failed 3 or 4 attempts of TISA. They have not found any sperm. So here we have been doing a lot, and you'll see the sperm, how it is. You can see it's completely abnormal. So what we have been doing, we have been taking this sperm, and we do the TISA first, because the patients they do not want any donor sperm. They don't want the pickup also to be done. Only if we find sperm, then only they'll go ahead. So these, many times we get 10 oocytes, we don't even get 3 or 4 sperm. So we're doing a micro TISA a lot, and this sperm we freeze using this new method, sperm VD. And we are happy that we even got a first live birth, normal live birth. But here also most of the sperms are abnormal, but we have been injecting them and we have been getting good live births. I will come to specific sperm defects. These are basically syndromes where there is all the 100% of the sperm will have the same defect. Like one is globospermia. I think most of you, many of you must have done cases of globospermia. Because it's a very rare case. Just 1% of the male infertility will have globospermia. The most important defect is here the acrosome is absent. That's why the sperm also appears like a round head. You have 2 different types. One is type 1, 100% round head and acrosome absent. Here to get fertilization is very, very difficult in such cases. Second one is type 2, 80% round head, and here you may find some small acrosomal cap and all, and here there is a possibility of getting some fertilization. Now the reason why we can't, even with ICSI, we do not get fertilization is because that sperm activating factor, the oocyte activating factor which is present in the acrosome is missing because the acrosome is absent. But here you can see there are some reports, where they've got pregnancies. They've got a pregnancy in globospermia where Y chromosome microdeletion was there. Even then they got a pregnancy. Then there is another report where they used artificial oocyte activation, where the PLC zeta was deficient. And with artificial oocyte activation and all, they were able to get a pregnancy and live birth in such difficult cases. Another case, immotile cilia syndrome. Here there is a morphological defect. The dynein arms are missing. That is why the tail, there is no movement. The axial filaments can't move. There will be 100% non-motile sperm, and of course, throughout the cilia also in the body will all be non-motile, but these are alive. So here you can do HOS, or sometimes even we have tried diode laser, but HOS I am very happy with it. Good normal morphological sperm, good head, and these we are able to get a good pregnancy, good live births. There is no issue with fertilization. Some of the defects we come across is stump tail defect, short tails. We have even tried doing TISA, but many times even in TISA we have found such sperm, but we are able to get good fertilization, good pregnancies. This is one case, I just got it in the literature study, abnormal head-tail junction. These, actually many times there were 2 brothers and both of them, they were able to conceive with this. Using this, they got fertilization. Many times, when you're doing ICSI, you find, especially when you're doing TISA sperm, the head detaches, It's many times, sometimes so often I get it in particular case, almost every sperm I'm trying to, cut the tail and the head gets dislodged. And in such cases, it's important that you should not just inject the head, because the centriole, which plays a very important role in fertilization, remains in the principal piece. That's why headless, the tailless sperm, you can see those the head, they do not normally fertilize. Then maybe you may get fertilization, but mostly it may be parthenogenetic. Then even in case of pinhead, there are 2 types of pinhead. One is headless sperm. There is no genetic material, just strand of tail. Here there is no possibility of getting fertilization. There is pinhead. Sometimes I did one case of pinhead, and I was fortunately I got a pregnancy and live birth also. Now I'll just come to the conclusion. Now with all this, we are using abnormal sperm to inject fertilization. So the question is, can abnormal shaped sperm fertilize an egg? Yes, the answer is yes. You can, and we have seen all the reports, everything. So the next question is, if an abnormally shaped sperm fertilizes the egg, Does it mean that my child will have higher risk of having genetic abnormalities? We can't actually say, but of course that possibility is always there. There are possibility you can get genetic abnormalities. So it is very important you counsel the patient, or you can do PGD, PGTA and all to check for all that. And finally, how important is sperm morphology? It's very, very important. So wherever possible, that's what we do. Even in where there is a syndrome, we try to look for a normal sperm, even round sperm. If there is some sperm we get with some acrosome, there's a big difference, then it is better, because finally what you want, you don't want just a healthy live birth. You want a baby, who doesn't have any further birth defects. With that, I would like to end my presentation. Once again, thank you all of you. Thanks the organizing team, and thank you chairpersons and my fellow speakers. Gaurav, thanks.
Thank you, Dr. Sudesh. That was a very nice presentation.
Quite comprehensive presentation. We are really grateful to you, Dr. Sudesh. Actually, this session is going very well in continuation with our orations. Like there's so many firsts. After hearing so many firsts in IVF and all in the field, hearing you, the first man in the ICSI, it's a privilege. So without wasting, since we are already running late, without wasting time in question answer, we will be keeping it in the last if time permits. So I would like to introduce our next speaker. May I have his slides, please? It's a privilege to introduce Dr. Gaurav Majumdar. He has done his MCE degree from National University, Singapore in 2001. And after that, he received his PhD in research in pre-implantation genetic screening for aneuploidy. He has done quite a lot work in pre-implantation diagnosis, PGTA. We have heard him so many times with his wonderful oration. In 2014, he successfully set up a PGS and PGD program, which now successfully runs an in-house genetic testing center facility using qPCR to screen embryos for aneuploidy. He has awarded the Economic Times Fertility Award for Best Embryologist of the Year in 2019. He has numerous publications in national and international journal and contributed 4 chapters in ART textbooks. He is treasurer in ACE and executive member of IFS India. So over to you, Gaurav. We are keen to hear you.
Thank you. Thank you so much for the kind introduction, Dr. Manisha. I'm just sharing my slides here. Yeah.
Yeah, perfectly visible.
All right. So it's been a wonderful morning, and it's my pleasure to be here. Always a pleasure to be a part of the ACE conference, and I would like to congratulate at the outset the organizers for doing a great job. So now I'm going to speak on a roadmap to choosing IVF over ICSI in non-male factor infertility. And we've had many lectures here which have been talking about the overuse of ICSI. Now, I have tried to present our personal data and have a different take on it to see if the message goes through. So as far as the evolution of ICSI is concerned, initially it was introduced specifically to tackle male factor. And then it evolved to obviously couples with previous total fertilization failures when subjected to IVF. But now these indications have evolved. And there are people who advocate the use of ICSI in non-male factor infertility, specifically patients with unexplained infertility, advanced stage, poor responders having very few eggs, then patients with endometriosis where egg quality is a major concern. And obviously we've heard that it is the go-to process for pre-implantation genetic testing and frozen oocytes. To an extent that now in majority centers across the world, ICSI is being routinely used in all IVF centers, in all IVF cycles across the board. So this graph here shows you this trend in use of intracytoplasmic sperm injection. And this is just from 1996 to 2012, where you can already see that 70 to 80% of the cycles which were originally being subjected to IVF now are being converted to ICSI. So this was in 2012. Now this figure of 70 to 80 has actually become 100% in a lot of cases. But what does the evidence say to suggest such a radical change from IVF to ICSI? Well, now there are umpteen papers, but I have put across here the recent 2 publications in 2021 itself, where the second paper from Dan Wing, and this is from Vietnam, has been published in Lancet. So this is the largest open label randomized control trial evaluating the efficacy of ICSI versus IVF in normal non-male factor infertility. And they have unequivocally stated that ICSI does not give any benefit. So despite evidence, why this radical shift? So I was thinking out loud, and I was thinking there must be some reason that we prefer ICSI over IVF. Perhaps it is in desperation for a procedure which could possibly eliminate failure of fertilization completely in IVF, or also perhaps holding a strong belief that injecting sperm into eggs will obviously lead to higher fertilization rates, and therefore will translate into more embryos at the end of the cycle. And as an embryologist, that is what my aim is, to be able to make the maximum number of utilizable embryos at the end of IVF cycle. Or it also helps us, performing ICSI helps us in providing a justification that we possibly did our best for our patients, possibly that, or a sign of dedication and hard work, that we left no stone unturned. Perhaps this is food for thought for everyone listening in. However, having said that, the dilemmas are real that we face in the clinic on a daily basis when we have patients with unexplained infertility, coupled with polycystic ovarian disease, when we have patients with grade 3 or grade 4 endometriosis, where we suspect poor egg quality, or patients who are going for their first cycles, but they have long-standing primary infertility. Then poor responders is a very tricky patient group where there are very few eggs. Advanced stage, more than 37, 38, 39, we feel, oh my God, who's gonna, how are we gonna decide whether it's gonna be IVF or ICSI? Then any patient who has had previously failed IVF ICSI cycles. So these are real dilemmas. And perhaps these dilemmas cannot be solved by reading articles, as evidence online. So we decide, and let me tell you one more thing, that as an embryologist for me, why this decision is so critical. Because based on my decision that whether I do IVF or ICSI for insemination is what will decide the eventual number of utilizable embryos at the end of an IVF cycle. And that is the most important key indicator of my performance, of my judgment as an embryologist. And I will show you how. So this is where the take comes in. So this is still unpublished data from my hospital, Sir Gangaram Hospital. So I have taken out some figures for these different patient groups. So first, let us look at advanced maternal age. So as you can see here, so I'll point my cursor here, that we did, the blue bars are IVF, the red bars are ICSI, and the third brown bars are patients where we did half IVF and half ICSI. So as you can see, 45% of our cases from 2019 were subjected to IVF in this advanced maternal age group, and ICSI was subjected to about, so half and half. So the first thing that I want to focus here is the oocyte utilization rate. So these are the number of metaphase 2 oocytes in ICSI which actually were subjected to injection. So you see there is a drop from 100 to 78%, right? And when we did half IVF, half ICSI, this obviously went up. So as you can see, the fertilization rate per oocyte was actually similar in all three approaches. But because of this reduction in oocyte utilization, the eventual fertilization rate per oocyte assigned, see there's such a big drop from IVF, 70% to 55%. So 15 percentage points translates to many embryos which could be utilizable at the end of a cycle. And now let's look at the total fertilization failure rate. So that was 5.9% in IVF, whereas in ICSI it was 8.3%. So this was a revelation for us. Let's look at the next patient group. Poor responders with very few eggs. So these are cases where we had 1 to 5 eggs. Here, look at the numbers. 60% of these cases in our center were subjected to IVF and only 40% were subjected to ICSI. This was a random choice based on clinician preference and patient history. So here, the oocyte utilization was actually higher than the previous group. It was 84%, but fertilization rate per oocyte in IVF was 75%, which is high compared to 67%. So 67% is not bad, but if we take into account the oocyte utilization rate, then you see the difference. 75% and only 56% in the ICSI arm. And let's look at the total fertilization failure rate. So there was 4.4% with IVF and 6.4% with ICSI. So again, a patient group where IVF did massively better. So we need to go back and think about our choice next time when we're dealing with few eggs. Let's now look at the most problematic group of patients, unexplained infertility with PCO. So here, understandably, the percentage of IVF, pure IVF, was only roughly 20%, whereas in 3 times more patients, ICSI was performed about 56%. Now, also to let you know that in this group, the mean number of eggs that were subjected to IVF was only 7. Whereas in the ICSI group, the mean number of eggs was about 11. And the moment we had a mean number of eggs because of the PCO component, it went around 22. We performed half IVF and half ICSI. So here in this group of unexplained, look at the oocyte utilization rate in ICSI. It is only 75%, which means 1 in every 4 eggs was excluded. So our starting number gets reduced by 25%. Then even though the fertilization rate with unexplained infertility in ICSI was way higher, 69% versus only 53% in IVF, unfortunately, because of this compromise, they come back at the same level. So we end up with a 53% in IVF and a 52% in ICSI. And whether we did half and half, it made no real difference. So perhaps this is the only group where making ICSI, performing ICSI is justified. Let's move to the next group, endometriosis. And why I have chosen these groups is because this is suggestive of poor egg quality. And somehow we have this thing in our head that poor egg quality requires ICSI, and we should not allow them to be subjected to IVF. Again, here you see that the oocyte utilization rate is pretty low, about 26 percentage points below IVF, but once fertilization occurs, all of them come at par with each other. And we observed no total fertilization failures with these patients. Now, another patient group that we struggle with is patients who are undergoing their first IVF cycles. Primary infertility, in some cases long-standing. You can see again that there's no difference between fertilization rates in IVF, ICSI, but because of a reduced oocyte utilization rate, there's a big difference in fertilization rates per oocyte. And as you can see that the TFF rates are minimal with 1 odd case. And that too, these are cases where only 1 or 2 eggs were retrieved. So very high chance of TFF can happen. Now, these are patients where there's been a past pregnancy, but no live birth, or there have been past live births. This is the last group of patients, which actually should be a no-brainer because obviously they've had past pregnancies. So these are patients where you'll encounter miscarriages, ectopic pregnancies, biochemical pregnancies, sometimes in the recent past and sometimes way back. So again, there is absolutely no difference in the fertilization rate per oocyte, where there's IVF is 70, ICSI is 69, so this is good news. But if we look at it per egg assigned, then there's a major difference that creeps in. Now, we took stock of all those cases where we performed half IVF and half ICSI. So we wanted to see what was the comparison between doing IVF and in ICSI in these cases. And obviously, so these were about 109 patients where we did this. And the mean number of eggs that were injected in the IVF arm was about 9, and ICSI understandably was slightly higher at about 10.7. But look at the fertilization rates, they were similar. But what I'd like to highlight here is that amongst the arm where IVF was subjected to these eggs, 78% of the eggs showed higher fertilization as compared to the eggs which were subjected to ICSI. So that's damning evidence in favor of IVF. So we do perform ICSI over IVF in the hope that it will lead to a higher fertilization. And higher fertilization means more embryos per cycle, a higher utilization rate, which is the ultimate aim, the ultimate KPI for any embryologist. And we also expect that there'll be no total fertilization failures. However, the reality seems to be a little different, because fertilization rates per allocated egg will always be lower in ICSI, as you have amply seen, as I have demonstrated to you. And a lower oocyte utilization rate will always translate into a lower embryo utilization rate. So you will not be able to compete with performing conventional insemination. And this again, as has been published by Dang et al. In Lancet in January, it shows that in these cases that the rate of TFF is absolutely equivalent between IVF and ICSI, where 5% was the TFF rate in ICSI and 6% was found in IVF. So to summarize then, using IVF in cases where there is proven fertilization with IVF in previous cycles, or previous natural conceptions, or previous missed abortions or ectopic pregnancies is a no-brainer. However, I'd like to recommend here that our data strongly suggests that IVF should also be used for cases where very few eggs are retrieved, 5 or less, in cases of advanced stage of more than 40, in cases of endometriosis where there's suspected poor egg quality. Then there is this is a very interesting publication that I recently found, where they said that patients with mild teratozoospermia actually have better live birth rate than IVF as compared to ICSI. Patients with previous failed ICSI cycles do actually very well with IVF. Then obviously this is a no-brainer that tubal factor with normal sperm does okay. And also our data shows that first cycles, young patients with short durations of infertility, IVF is the method of choice. The only prerequisite for performing IVF is a good post-wash swim-up motile sperm count. If that is lacking, then unfortunately you have to resort to ICSI. And I'd like to end here with words of Hans Evers, who was the editor of Chief Human Reproduction, that it is not like the therapeutic illusion of the old. And here, in the field of ART, patients will get better without treatment, which is IVF, but will also do so with ICSI. No, this treatment actually may hurt a couple's chances, and that too by making fewer embryos. So it is a crucial choice because it determines the number of utilizable embryos at the end of a cycle. And if I think about which patients can this procedure hurt or be detrimental to, it will be patients with few eggs or immature looking OCCs, advanced stage, repeated cycles where ICSI has been performed with no indication, and suspected poor egg qualities. So thank you very much for your attention, and I'll be open for any questions.
Thank you, Gaurav, for your nice presentation. It is really enlightening with all this data on table. I think we have been told before that since we are running late, we will have the discussion at the end. Manisha, am I right?
Yeah, perfectly fine, ma'am.
Yeah, yeah.
But it
So,
was great from Dr. Gaurav. I must congratulate
Gaurav,
you to
yes,
take
I must
opportunity of
congratulate.
this talk. Actually, this is real eye opener, and it
Yeah,
is
yeah.
heartening to see that our own scientists, instead of running for aberrant high claims for the success, we are talking about the real truth. So it's
Yes,
brilliant.
we
Must congratulate you.
must, yeah. This is this. There is nothing called as the ICSI for all, which most of the scientists are advocating for, because at the end of the day, it is the quality of the oocyte that also matters. So there is always a debate between the seed and the field. So let us judge the field and the seed equally, giving equal importance to either of them, then decide what to do and what not to do. Thank you, Gaurav, for this illuminating talk. Really enlightening. Thank you, all the S members, for this opportunity to listen to such an illuminating talk. Okay, we can have our next speaker, and I request Dr. Manisha to please introduce the other person as well.
It's a privilege to introduce our next speaker, Mrs. Rashmi Goenka. She is a laboratory director at Institute of Human Reproduction, Guwahati. She has completed her master's in clinical embryology with a distinction from Leeds University, UK. She is working at IHR for nearly 15 years now. She has done more than 10,000 IVF cycles. She has experience hand in ICSI, vitrification, blastomere biopsy, trophectoderm biopsy, and oocyte vitrification. So over to you, Rashmi. We are keen to hear you.
Thank you so much, Dr. Manisha. And I'll share my screen right now.
Yeah, it's absolutely.
So a very good afternoon, everyone. And first of all, I would like to thank ACE 2021 Kolkata for giving me this opportunity to speak in front of such an august gathering. Thank you, Dr. Ratna ma'am, Saroj, and Parag for this opportunity. So the topic of my presentation today is fertilization failure, what next? Or should I say total fertilization failure, what next? So let's look at a scenario. Mrs. ABC, 29 years, married to Mr. XYZ, 32 years, for 5 years. Primary infertility for 2 years. History of pulmonary TB 3 years back. On evaluation, HSG was suggestive of bilateral mid-tubal block, advised IVF, and on retrieval, 14 oocytes were retrieved and IVF was done. The next day, when we embryologists, we looked through the microscope for fertilization check, expecting to see 2 beautiful pronuclei. We see nothing. There's no 2 PNs seen. So it's a state of panic. We wait for 2 hours. We again go and check, but alas, there are no 2 PNs seen in any of the oocytes. And the dreaded news hits it, a case of total fertilization failure. What is total fertilization failure? It is the failure of fertilization of oocytes in the absence of obvious sign of male and female pronuclei at a standard checking time. Acceptable fertilization failure rate is around 20%. So that is, if we have inseminated 10 oocytes, we expect 8 of them to be fertilized. That will give us a good embryo development. Elevated fertilization failure rate is when fertilization fails in more than 30% of the oocytes, and total fertilization failure rate in IVF or ICSI is when we have no fertilization. Possible consequences. Fertilization failure is one of the causes of infertility that only becomes evident after IVF and ICSI is performed. Consequently, under these circumstances, both patients and the medical staff are under great stress. In point of patient's view, financial, a lot of consequences, because it's not a matter of 1,000 to 2,000 we're talking about here. They have spent lakhs, 2 lakhs. Emotional, a lot. It will be a tremendous emotional trauma on them if they come to know that their gametes have failed to fertilize and they will have no embryo for transfer in that cycle. And of course, then the patient has questions on the competency of the clinic. Consequences on the embryologists, we have to take 100% of the blame, and then we decide to go for all ICSI in future cases. But is this correct? In the previous talk by Dr. Gaurav has given us food for thought on this issue. Apprehensive clinician, of course, it's the clinician who has to face the patient, and they might go for empty transfer or even go for the unethical practice of embryo donation without consent. So in the next 5 to 7 minutes, let's learn about total fertilization failure, how common it is, why does it happen, can we predict it, and can we prevent its recurrence. Incidence of total fertilization failure in IVF cycles is around 5 to 15%, ICSI cycles around 2 to 3%. Because we must know that even on ICSI cycles, we can have chances of total fertilization failure because ICSI addresses only one of the necessary components required for successful fertilization, that is sperm penetration. For fertilization, the gametes need to be genetically normal, mature, and there should be nuclear and cytoplasmic synchrony maturation in oocytes. Oocyte maturation refers to the completion of first meiotic division and accompanying processes essential for subsequent fertilization and embryo development. It consists of two components, nuclear maturation and cytoplasmic maturation. Now on nuclear maturation, what we morphologically see when we look through the microscope is either a GV oocyte, that is prophase 1 diplotin stage, a germinal vesicle breakdown oocyte, that is metaphase 1 stage, and an oocyte with extrusion of first polar body, that is metaphase 2, or a mature oocyte ready for fertilization. What we don't see, but what happens during nuclear maturation is condensation, chromosome alignment, and accurate spindle formation. Cytoplasmic maturation is less well defined and understood, but equally essential. Proper relocation of organelles, synthesis of proteins, and post-translational modification of messenger RNAs, which gets accumulated in the oocytes during oogenesis, is required for successful completion of meiosis and further processes like fertilization and pre-implantation embryo development. Nuclear and cytoplasmic maturation is a coordinate event. Many aspects of cytoplasmic maturation are, however, independent of nuclear maturation, and the so-called mature oocytes, which we see, may actually be lacking the essential maternal factors required for subsequent fertilization, PN formation, and embryo development. Steps of fertilization can be divided into two groups. One is pre-sperm penetration, and the second is post-sperm penetration. So let's see the pre-sperm penetration. It's number 1, the cumulus cell penetration, 2, sperm oocyte binding and zona pellucida penetration, and 3, oocyte sperm fusion. For the post-sperm penetration, we have oocyte activation by the calcium influx, sperm processing, that is the decondensation and condensation of the sperm, and PN formation. Now, in IVF, problem for total fertilization failure may arise in any of the two steps, that is pre-sperm penetration and post-sperm penetration. But in ICSI, as we are directly placing the sperm inside the cumulus of the oocyte, we generally hop off the first group and problem may arise in the post-sperm penetration. Total fertilization failure after ICSI primarily may arise due to oocyte activation failure in 50 to 60% of the cases, premature chromosome condensation in 33% of the cases, unsuccessful decondensation of sperm chromatin in 5 to 10% of the cases, and spindle defect and sperm aster defect in 6 to 18% of the cases. Methodical errors by the embryologist just said 7 to 12% of the cases, but we are often blamed 100% for it. TFF after IVF, The reason may be the pre-sperm penetration problems, that is no sperm incorporation, and along with it, all the other post-sperm penetration problems. Risk factors for TFF: increased age more than 35 years, diminished ovarian reserve, retrieval of fewer oocytes, that is less than or equal to 3 in poor responders, immature oocytes is more than 25%, unexplained infertility and non-tubal factor infertility, female smoking, yes, it does hamper the pre-sperm penetration steps, previous history of TFF, abnormal sperm morphology, and new embryologist. But 60% of the TFF cycles are from poor responders. Solutions for TFF in IVF: rescue ICSI, that is the next day we take the unfertilized oocytes and inject the day-old oocytes with the partner sperm. We do get fertilization in rescue ICSI, but pregnancy rate is really poor. We used to do rescue ICSI in our center, but we've totally abandoned it for the last 8 to 10 years by improving the number of mature oocyte retrieval and ICSI in future. Solution for TFF in ICSI: repeat ICSI or modified ICSI, where we mechanically stimulate the organelles inside the oocyte by taking in a little bit of cytoplasm and placing it back inside the oocyte along with the sperm. This is a kind of mechanical oocyte activation, and we do modified ICSI in our center for all oocyte Thaw cases. Then ICSI can be done with IMSI, ICSI can be done with PICSI, spindle fugue, and artificial oocyte activation by using solutions with calcium iron phos. Outcome after TFF: fertilization rate, like in the first TFF cycle, if we have done IVF and we go for ICSI in the next cycle, fertilization rate do improve to 50 to 80%, but live birth rate is low, it's only 5 to 15%. So studies indicate that couples with TFF after IVF with normal semen quality have high fertilization rate after ICSI, but a lower pregnancy rate. Recurrent TFF in IVF cycles, we can have up to 30%, and even in ICSI cycles, repeated TFF can be up to 15%. So we can say that TFF is not a random event, and maybe we can predict it. Further evaluation of TFF to identify sperm and oocyte-borne causes, which is the culprit gamete. So ways to do it: cross test to detect the defective gamete, fertilizing the woman's oocyte with donor spermatozoa and donor oocyte with husband spermatozoa. Split fertilization: sibling oocytes are fertilized with partner sperm and donor sperm. And mouse oocyte activation test. This can be done, but theoretically and in research labs, in practical day-to-day running lab, this is not possible. This is not practical. So cross-test and split fertilization can be done after counseling the patient, and it can be performed only during repeat cycle, and patient must agree for gamete donation. And I would just like to share an incident, a case we had a few years back, where this was a patient with total fertilization failure even after ICSI. So we counseled the patient. We first did a repeat cycle, and in the second cycle, we did ICSI with MAX and PICSI dishes. And we counseled, but still the fertilization, we did not get any fertilization. And we knew that recurrence was because there was some fault in either of the two gametes. So we counseled the patient for cross test. The patient agreed, and the patient was prepared for with ovarian stimulation for fresh retrieval of oocytes, and consent was taken for donor gametes of both oocytes and sperm. And we did cross test for them, and we found the culprit gamete. We got embryos, and we transferred. The patient was pregnant and has a healthy baby. But to the surprise of us, the patient refused to know which gamete was the culprit. So even till date, they are not in positive to know which was the donor gamete that was given to them. So I would conclude by saying that sporadic total fertilization failure could imply a modifiable condition for which further treatment can produce encouraging results and is therefore recommended. but recurrent TFF has poor prognosis, representing severe gamete defects for which use of cross-testing followed by donor gametes may be a valid option. Thank you.
Thank you so much, Rashmi, for your brilliant presentation. It was really enlightening to see your work and heartening to attend your talk. So may I request Dr. Luna to introduce our next speaker?
Thank you, Dr. Manisha. It will be my pleasure.
Actually, no need of introduction because I have already twice introduced. I'm sitting here since morning. So,
actually, you don't need an introduction, Dr. Rashida. You are so well known in not only in India but abroad as well. So wherever you go, you will definitely find an oral presentation of Dr. Rashida, and it is always a privilege to listen to you. You are welcome, ma'am, for your talk. You are waiting for long. Yeah, yeah.
Is it visible?
Yes, ma'am.
So thank you all. You have faced lots of trouble with my internet connection and computer device. It disturbs so much. It never happened like this. So good afternoon, everyone, and thank you, organizer, for inviting me to say something on embryology, because this is a program of embryologists. Being a gynecologist, to say something on embryology is very difficult among the midst of these very talented embryologists. So it is a sort of dare approach of mine, but still I'm trying to say something. Though my topic is round spermatoid injection, I don't have any experience of myself. I shared the experience of others, but I had the opportunity to visit the center of in Japan to see Roshi, and from there I'm going on just theoretical. I don't have any practical experience. So for 40 years have passed since the first intracytoplasmic sperm injection, which was introduced for severe male factor infertility like severe oligospermia and azoospermia. Hiramoto in 1962 successfully fertilized sea urchin eggs by microinjection of live spermatozoa. 30 years later, this technique was introduced for the treatment of human fertility. We know Palermo et al. Introduced in 1991 and baby born in 1992. Today, ICSI is the state of the art in ART, gives solution in severe male factor infertility. So there are still cases of azoospermia where ICSI is not the answer. ICSI is possible even after micro-TC, where spermatozoa, full-blown spermatozoa is not available. In such cases, spermatid injection is considered as a promising alternative. Spermatids are the youngest male germ cells with a single set haploid chromosomes. After completion of secondary meiosis, spermatids undergo a complex cellular differentiation and maturation process known as spermiogenesis. One of the most important changes that takes place in this process is nuclear DNA packaging, replacing histone by proteins. In few instances, this maturation process does not take place and is called maturation arrest, resulting in absence of spermatozoa in ejaculate. It may be early arrest occurs in the spermatogonia or primary spermatocyte stage, or in late arrest in spermatid stage. Overall sperm retrieval in these maturation arrest cases is 52%. More in late maturation arrest cases, that is in case of round spermatid, and early than early, the 78% versus 40%, and more in focal than diffuse maturation arrest, 48% in focal, and in case of the diffuse, it is only 19%. In this picture, it is shown that this is the dilated seminiferous tubules, in case of maturation arrest patient. In other places, there is no dilatation of seminiferous tubules, only a portion of seminiferous tubules are dilated and spermatozoa got from that places. This is focal maturation arrest. The evidence of round spermatid injection in human. First Roshi generated baby was reported by Tassadik and Mendoza in 1996. Out of 39 eggs injected by Roshi, of 14 men, 35% of such developed embryo, which transferred and 2 singleton babies were born. Subsequently, several investigators reported both live birth and ongoing pregnancies. But another group were very much disappointed because most of other investigators reported unsuccessful attempts of ROSI. So practice committee of ASRM and the practice committee of Society for Assisted Reproductive Technology considered ROSI an experimental rather than a recommended practice. So clinicians' interest of ROSI faded away very quickly. But challenges was taken by a Japanese investigator named Tanaka. Tanaka and his associates in the Saint Mother Clinic continued ROSI in response to requests from couples after extensive counseling. In spite of knowing everything, the success rate is very, very low. 90% of them desire to try ROSI. And since then, he is doing ROSI, and 14 babies, a paper published in 2015 with 14 babies, and another paper published in 2018 with 90 babies. Hanson BM conducted a meta-analysis of 22 publications till 2018 involving 1,099 couples and 4,218 embryo transfer. Overall fertilization rate was 38.7%, pregnancy rate was 13.38%, and live birth rate was 8.1%. Out of 1,099 patients, 721 dealt in on-center, and out of 89 pregnancy, 84 pregnancy occurred in that center. So it is not extensively used all over the world, but this center dealt with a large number of patients. Why pregnancy rate is so low? Human spermatozoa must be capacitated, hyperactivated, acrosome reacted, after which they pass through the oocyte's protective vestments and finally fuse with the oocyte. ICSI bypasses all the events. All that is needed for fertilization is a single spermatozoa with a normal genomic constitution. In case of ROSI, which completed the second meiotic division, which acquired haploid number of chromosome, contains that genomic constitution, it remains the same. In spite of that, why there is no fertilization or pregnancy? So what is the problem in case of ROSI? Main problem is identification of round spermatids, that is injection of appropriate round cells. There may be other cells like sertoli cells, spermatocytes, spermatogonium, and other blood cells, etc. So incidentally, there may be injection of other cells instead of round cells. Then activation of oocyte. There may be defective or inappropriate activation of oocyte in case of ROSI. And centrosome maturation or genomic imprinting also may be defective. So identification of round spermatid is really problematic. A standardized set of criteria of round spermatid identification was not available prior to the study done in Japan by Tanaka. So he fixed the criteria for identification on his size. Size of round spermatid is 6.5 to 8 micrometer, which is a smaller cell. And this cell, this type of cell only lymphocyte and RBC, but other cells like spermatogonium, sertoli cells, and primary spermatocyte cells are bigger than round cells. The nucleoli, in case of spermatogonium, there are nucleoli, but it lacks nucleoli. Pseudopodia, pseudopodia is present in spermatogonium, which is not present in round cell. And acrosome vesicle or cap is present in round spermatid, but sometimes this may not present. So absence of this cannot exclude round spermatid, but presence indicate that it is round spermatid. And it is this visual judgment of selection of spermatid is confirmed by doing fish. Actually, by fish and karyotyping, this can be confirmed, but in that case, it is not used in for ROSI. So it is difficult to identify in the field of action. So after that, the presumptive round cells are tested, and here is single dot indicates a single chromosome, either green is either X or yellow. So, and diagrammatically, it is shown that nucleoli is present in spermatogonia, pseudopod is present, but in case of spermatid, this Golgi vesicle, acrosome cap is present in case of spermatid. Another way of distinguishing spermatid and spermatigal from somatic cells, when spermatid is sucked in and out of micropipette, its plasma membrane is readily broken, and nucleus of cytoplasm are separated, and nucleus appears as a clear sphere. Sometimes it is turbid, that is when apoptotic spermatid is present, it is turbid, and apoptotic spermatid, when injected, it does not cause fertilization. A spermatogonium also can be separated in the nucleus and cytoplasm by pipetting, but nucleus, unlike spermatid, contains clearly visible on or more nucleoli. And somatic cells such as interstitial cells, fibroblasts, blood cells, leading cells released in the medium during maturation of seminiferous tubules have flexible plasma membrane which cannot be readily broken. How to differentiate live round spermatid from lymphocytes and erythrocytes? The diameter of round spermatid is approximately similar to that of erythrocytes and small lymphocytes. So by backward and forward movement of live spermatids within injection needle, gentle movement, but vigorous movement can cause breakdown. Gentle movement through the needle, it is deformed but does not break. But after release from the needle, the shape come back again. And it is not adherent or sticking in the internal leaf. But in case of lymphocytes, it becomes adherent with the inside of the needle. And cytoplasmic nuclear cytoplasmic ratio is more in case of lymphocyte, and nuclear shape of the nucleus is kidney shape or round, and placement is eccentric. And developing acrosome is present in round cells. So oocyte activation. Next is also defective oocyte activation. Without good oocyte activation, good embryo development cannot be expected. During normal fertilization, sperm-borne oocyte activating factors triggered oocyte activation. In animal studies, it is proved that sperm contain oocyte activating factors. So phospholipase C zeta and post-acrosomal sheath protein are the two strongest sperm-borne oocyte activating factors. But Ijawa et al. Described that human spermatid also contains some active sperm-borne oocyte activating factors. And this may help, but still oocyte cannot be activated. So vigorous aspiration of cytoplasm sometimes helps to activate. Other options, calcium ionoprone and serine, are known to trigger release of calcium from oocyte's internal structure, can be used for activating Rossi oocyte. And injection of phospholipase C zeta into human oocytes induces typical calcium oscillation. And electrostimulation is also other option. And some studies shows that frozen spermatid needs, sometimes it does not need oocyte, external oocyte activation. And this can activation can happen when inject frozen spermatid. The round spermatid injection is conventional needle, can be done with this, but piezo needle is appropriate because piezo needle is blunt and caliber is larger. It needs at least 8 micrometer diameter. So external injury is less with piezo needle. So what is the evolution of Rossi? In back 2000, there was a study, poor outcome with round spermatid injection in azoospermic patients with maturation arrest. And here they compare with conventional ICSI, that is ICSI with mature spermatozoa and ICSI with Rossi. And they found that fertilization rate is 44.9% in Rossi ICSI and 69% in mature sperm ICSI. But there is no pregnancy. Though fertilization rate is low, but it is not nil. But pregnancy was nil, whereas with mature spermatozoa, it was 50%. So they concluded that in azoospermic patients with maturation arrest at the stage of round spermatid, the efficacy of Rossi appears to be extremely poor. And another study shows that for 22% among round cells, 22% cases may grow flagella after culture, and then fertilization may take place. Then in Tanaka, who shows with 14 babies, this paper published in 2015, he also compared Rossi ICSI and ICSI with mature spermatozoa. And he shows that pregnancy was 23.8% in case of Rossi and 60% in case of mature spermatozoa. But abortion rate is very, very high in case of Rossi. It is 50%. And in case of mature spermatozoa, it is only 8%. So ultimately, live birth is very, very low in case of Rossi, only 11.9%. In comparison to mature sperm, 55.2%. So, but with immature spermatozoa, result with elongating or elongated spermatozoa is better than round spermatid. And here it is shown that with elongating spermatozoa, it is almost 71% fertilization, but in case of round, it is 26%. So how to improve the result? So this round spermatid can be co-cultured with Vero cells, and after co-culturing with Vero cells, it is found that round spermatid can develop elongated or elongating spermatozoa or complete spermatozoa with flagellum. And Aslam and Fischel shows that 22% of round spermatids grows flagella. So at least this 22% can be injected by observing confirmed spermatozoa. There is no chance of injecting other cells. So if we can do co-culture with Vero cells, it can be grows up to mature spermatozoa sometimes. Till today, so far, more than 500 healthy Roshi babies are born in that center, that is St. Mother Clinic, and most eldest baby married and had healthy baby boy at the age of 24. The average birth rate is only 9%, and miscarriage rate is 40 to 45%. Still, it cannot be overcome. The main cause of poor clinical outcome was proved to be originated from epigenetic abnormalities. They have been experimenting to overcome the cause by two methods. One is in vitro co-culture with round spermatid with cytolysis, and other is use of histone deacetylase inhibitors. So, what is the safety of Roshi? The 90 babies were observed till their age 2 years by observing physical and cognitive development and congenital anomaly rate. Only 3 babies developed congenital anomaly. On is ventricular septal defect, which is corrected spontaneously. Other 2 cleft lip and omphalocele, which is corrected by surgery. But it concluded that there were no significant differences between Roshi and naturally conceived babies in either physical or cognitive development during the first 2 years after birth. So in conclusion, it can be said that men without spermatozoa or elongating spermatids in their semen have been considered sterile and are advised to consider using a sperm donor. However, these men may have round spermatids. Round spermatid injection was done effectively by different scientists and resulted in birth of healthy babies. Although the current success rate of round spermatid injection is not very high compared with intracytoplasmic sperm injection, this procedure can be last resort for men who cannot produce spermatozoa but wish to use their own genetic material to produce offspring. Thank you for your patient sharing.
Thank you, Dr. Rashida. Actually, we extend our apologies that you are waiting since morning, but at the end of the day, everything that ends well is good. Dr. Sharoz, do we have any time for discussion, or we'll move on to the next session?
No, ma'am.
Ma'am, we have to move on to the next session, which is taking place in Hall A. So thank you so much to all our speakers for the excellent presentation. It was very informative, and thank you to our chairpersons for moderating the session. Thank you so much. Due to paucity of time, as mentioned, we will not be able to have a discussion. The TC Anand Kumar oration is going on in Hall A. So requesting all to go there and then join back in this hall after 1 hour.
Congratulations for such seamless organization to Team ACE. You all deserve a big round of applause.
Yes.
Great job. Thank you.
Thank you. Thank you all. Thank you for giving this opportunity.
Thank you.
ହଁ ନା ଭଲ ହେଲା ଠିକ ମୁଁ ଜଷ୍ଟ ସରିଛି ତମେ ମତେ
Hello, Dr. Pranab.
Yes, hello.
I was saying that right now oration is going on in Hall A. So
Okay.
the session will start at after the oration.
Okay.
So it will be start on like 2:45.
Okay, so should I leave?
Yeah. So join at like 2:40 or 2:35, or you can be like, yeah.
Okay, I'll join by 2:30 then.
Okay,
Thank
sir.
you.
Okay. Shakir. Hello, Sonu sir.
Yes, hello.
We'll be starting soon.
Sure. Yeah.
Himanshu, can we start?
Yes, Rashi, we will.
Okay. Welcome back to Hall B. This is the final segment of ACE Kolkata. We will commence the session, which is a series of free papers, miscellaneous. I would now like to call upon our chairpersons for this session, Mr. Sonu Shaw and Dr. Shaporna Banerjee. Can I have the series slides, please? Mr. Sonu Shaw is a senior embryologist at Birla IVF Fertility, and he's done his MSc and PG diploma in clinical embryology and ART. He was previously associated as a senior embryologist at Indira IVF Hospital Private Limited and was an embryologist at Ridge IVF Private Limited. Welcome to the session, sir.
Thank you.
And can I have the next slide, please, of Dr. Shaporna Banerjee? Himanshu, the next series slide, please.
Give me a second.
Himanshu, is there an issue with the slides?
Yes, let me.
So I have the CV with me. I can just read it out from here.
Yeah, I think you go ahead. We need to start. We are getting late anyway.
Yeah. So Dr. Shaporna Banerjee has passed MBBS in 1997 with distinctions in biochemistry and pharmacology from RG Medical Hospital. She has done her MD in DGO in the year 2002 to 2004 from RG Medical College. She's worked as an IVF specialist in Peninsula Center for Reproductive Medicine in UK from 2008 to 2011 and is a member of Royal College and British Fertility Society. She is the director of Ankur Fertility Clinic and Research Center and is the secretary of IFS. Is also the secretary of Bulletin and Website Subcommittee and assistant secretary of Scientific Committee of AICOG. Welcome to the session, ma'am, and over to you both for chairing the session. Thank you.
Thank you, Rashmi. Okay, so our first topic is polymorphism of TSPY1 gene associated spermatogenic failure among men from West Bengal. So I'll be, it's very interesting topic because we do not know much about it. So our speaker, Pranab Palodhi, will enlighten.
Ma'am, he is not joined yet. You can call the second speaker.
Okay. Okay, we are going then to the second topic, which is impact of shelf life of culture media on embryo development. And this is the speaker for this topic is Swarnamugi Varadaranjan. Okay, can I have the CV, please? Okay, so our esteemed speaker is working as the junior embryologist in ARC International Fertility and Research Center, and she is she pursued her master's in genetics engineering at SRM University for the academic year 2015 and 17. So she is very junior to me. So okay, so stage is all yours. So you will enlighten us regarding the shelf life of embryo culture on the embryo development, shelf life of the media. Yeah.
Thank you, ma'am. Thank you for the warm welcome. So let me share my PPT right now. Okay. Good afternoon to all. I'm Swarnamuki, working as a junior embryologist in ARC International Fertility and Research Center. So before I go to the topic, I'd like to thank all the organizers of ACE 21 for selecting me and letting me to present in this forum. So let me take you through my presentation. So the topic of the day is impact of shelf life of culture medium on embryo development. So introduction. So culture media contain up to 80 components, which also includes salts, serums and buffer solutions, and nucleotides, amino acids, etc. So effective buffering potential of culture media provides a safer and a stress-free environment for the embryo development. So during the pandemic, there was the manufacturing and the distributing companies faced a lot of shortage in the personnel and the maintain regular delivery schedules. So ART clinics around the globe had a delay in supply of media brought about by the lockdown and the logistic issues during COVID-19 pandemic. So the media used for the study is single-step media. So the objective of the study is this study aims to evaluate the performance of the culture medium within its shelf life. So this multi-centered retrospective study included a total of 1,290 autologous patients who underwent ICSI treatment from July 2020 to July 2021. So the blastulation rates were studied, and the culture conditions were maintained, that is the temperature, the pH levels and the gas levels and VOC, etc. were regularly checked and maintained. So the shelf life of the single step media used was approximately 7 weeks. So the patients were classified into 4 different groups. One is group 1 had a total of 241 patients cultured in the first 2 weeks of media opening. And group B had a total of 258 patients cultured in the 3rd and 4th week of the media opening. Group C had a total of 180 patients, which included cultured in the 5th and 6th week of the media opening. And Group D had a total of 611 patients cultured in the 7th week of the media up to the expiry. So I have classified all the 4 groups separately, and all the parameters that were studied are listed in the graph. So Group A had a total oocytes of 3,070 oocytes, amongst which 2,221 oocytes, matured oocytes were injected, and a total of 1,014 embryos were frozen. In group B included a total of 3,299 oocytes, and out of which 2,412 matured oocytes were injected, and a total of 1,089 embryos was frozen, and which equal to 52% of conversion. And in group C, a total of 2,359 oocytes were taken, out of which 1,693 oocytes were injected, and a total of 782 were frozen embryos, which led to 50% of conversion. And finally, group D had a total of 8,006 oocytes, amongst which 5,765 mature oocytes were injected, and a total of 2,482 were frozen, which is 49% of conversion. So the methodology. Here, the freezable blastylation rate was studied for each group. As per our lab protocol, they were further divided into two. That is low conversion, wherein up to 30% of blastocysts frozen out of number fertilized, and a high conversion of above 30% frozen out of fertilized oocytes. So the amount of high and low conversion were compared between the individual groups as well as between the groups, that is A plus B plus C together and the group D separately. So the result was statistically analyzed using one-way ANOVA. In the table, I have mentioned the high and the low conversion numbers out of the total number of patients. And this graph represents all the parameters studied in the combined groups. Here, we have taken the total of fertilized oocytes and total of frozen embryos in each groups, group A, B, C, and D, and the conversion was calculated. Here, the overall blastylation rate was 51%. So the intercomparison of a good or poor blastylation rate of two independent groups showed no significance. Combining A, B, and C with group D displayed a significantly higher rate of poor blastylation. So a significance of 0.0005 was obtained using the ANOVA. So the conclusion of the study was, it suggests an ideal period of media usage. So depletion of nutrients and changes in the pH with prolonged media usage could deteriorate the blastylation. It also highlights if this media is used after 6 weeks, it has a significant impact on the developing embryo. So still considering the buffering potential of any culture system, an extended usage can be recommended within the expiry. So these are my references. So I finally would like to convey my sincere thanks to my MDs, Dr. Lakshmanan Saravanan and Dr. Mahalakshmi Saravanan. I'm also obliged to careful guidance from my lab director, Mrs. Sarguna Devi, for prompting me in conducting the study and helping me throughout the study. My heartfelt appreciation to my colleagues who had helped me in collecting and processing the data with impeccable precision. Thank you for your patience.
Okay. So it was a very hard work for you, I guess, and yes, a lot of data I can see. Excellent work. So I think if there is any question, we will take it later at the end of the session.
Sure, ma'am. Thank you.
Okay. Okay. So the second one will be the topic polymorphism of TSPY1 gene associated spermatogenic failure among men from West Bengal. And the topic will be dealt by Pranav Palodhi. Pranav, are you here?
Yes, ma'am. Am I audible?
Yes, you are. It's a very interesting topic here.
Thank you.
Yeah.
Looking forward to it. Ma'am, my slides are visible?
Yes, it is. Yes, go ahead.
Okay, thank you. First of all, good afternoon to all the respected delegates, all the faculties and researchers. I am Pranav Palodhi, Senior Research Fellow, Cytogenetics and Genomics Research Unit, Department of Zoology, University of Calcutta. I am pursuing my PhD under Dr. Sujoy Ghosh Associate Professor, University of Calcutta. First of all, I would like to thank to the entire organizing team for providing me an opportunity to present my research work on this platform. Today, the topic of my presentation is polymorphisms of TSPY1 gene associates spermatogenic failure among men from West Bengal, India. To begin with, I must define infertility, which is basically the inability of a couple to conceive after 2 years of unprotected sexual activity as defined by the World Health Organization. Testis-specific protein Y-encoded 1, that is TSPY1 gene, is located at Y chromosome. The transcription unit of this gene is 2.8 kb long, consisting of 6 exons, that is the coding regions. Now, this particular gene is primarily known for its implications in development of gonadoblastoma, testicular and prostate cancer, but there are several studies which anticipated that this gene can be involved in the regulation of spermatogenesis process. Regarding the research works, there are several studies including sex chromosome copy number variations and autosomal gene polymorphisms, but surprisingly, studies on the Y chromosome genes and the genes controlling spermatogenesis process are not that much available, and especially the genetic screening for male infertility in West Bengal population is totally lacking. So the objective of this study was to find out whether there is any association between TSPY1 gene polymorphisms and male infertility in West Bengal population. So we have worked with 3 different polymorphic variations of TSPY1 gene, first of which is an exonic variant RS135888900 C2T substitution. This is, as I said earlier, is an exonic variant, that is a coding variant which corresponds to an amino acid change from proline to leucine at the 109th position. The second polymorphism is RS12970595542 G2A substitution. This is again an exonic variant and it corresponds to an amino acid change from glycine to glutamic acid at the 190th position. The last polymorphic variant is RS566754601 G2A substitution. This is an intronic variant, that is a non-coding variant, and hence does not correspond to any amino acid change. Coming to the materials and methods part, it is a hospital-based case control study. All the samples were collected from Kolkata and its surroundings. The samples were taken only after taking full consents from the participating families under the governance of our physician collaborators. And the research work is well authenticated by the Ethical Clearance Committee of University of Calcutta as well as Institute of Reproductive Medicine, Kolkata. So in the first step, the patients with idiopathic, that is unexplained male infertility, were diagnosed and their semen samples were collected. Then patients with chromosomal abnormalities, varicocele and cancers were excluded. Then agiospermic and oligospermic patients were detected via seminogram by our physician collaborators, and they were included in our study as case individuals. We have already included age-matched healthy individuals with proven paternity as controls in our study. And then blood samples and epidemiological data were collected from the selected individuals. In the next step, we isolated the genomic DNA from the obtained samples. Then we designed specific primers for TSPY1 gene, and we proceed to polymerase chain reaction for amplifying the required portion. Then we were up for Sanger sequencing and detection of polymorphic variants, and thereby we proceed for in silico and suitable statistical analysis. Coming to the result part, to assess the association between TSPY1 risk alleles and male infertility, for the first polymorphic variant, RS135888900 C2T substitution, we have taken the major allele C as the reference, and the minor allele T showed compelling confederacy with male infertility. Here, the odd ratio is 2.711 and p-value here is 0.0103. In case of the next polymorphic variant, RS12970595542 G2A substitution, again, we have taken the major allele G as the reference, and the minor allele A was found out to be extremely correlated with male infertility against the odd 1.971, and here the p-value is 0.0216. And in case of the last polymorphic variant, RS566754601 G2A substitution, the minor allele A was very much correlated with male infertility. Here the odd ratio is 2.411 and the p-value is 0.0051. So in all the three cases, the p-value came out to be very significant. And here the bar graph shows the frequencies of the major and the minor alleles in both control and case samples in case of all the three polymorphic variants. Then we also detected the plausible damaging effects of the polymorphic variants by in silico analysis in the context of creation or loss of alternate splice sites on the transcripts. Here is the pictorial depiction of the transcription factor binding sites in reference or wild type sequences as well as the mutated sequences. And the red boxes indicates the change in the transcription factor binding sites due to these three polymorphisms. Then we were up for the functional predictions also of the polymorphic alleles through in silico analysis using two different softwares, that is Polyfen2 and SIFT. These softwares generally uses several different algorithms for the functional predictions, and both the softwares predicted all our three polymorphic variants as either probably damaging or deleterious. So in a nutshell, we can conclude that TSPY1 gene polymorphisms increase risk of spermatogenic failure in Bengali-speaking men, as it can lead to either complete absence of sperm or it can lower the sperm count. The minor alleles of the SNPs RS135888900 C2T substitution, RS1297059 G2A substitution, and RS566754 G2A substitution individually increase the risk of male infertility by 2.711, 1.971, and 2.411 folds respectively. But lastly, I must confess that these are our primary observation, and this study needs confirmation through population-based replicative studies on other ethnic groups with larger samples. Now, I'd like to express my thankfulness to the Department of Zoology, University of Calcutta for providing me such atmosphere to work, Institute of Reproductive Medicine for supplying all the samples, Indian Council of Medical Research for funding our research work, and all the physician collaborators and participating families for their continuous support. I'd like to thank Dr. Shujoy Ghosh, my supervisor. He's an associate professor, Department of Zoology, University of Calcutta. I also thank Dr. Boidyanath Chakraborty, Director, Institute of Reproductive Medicine, and Dr. Ratna Chattopadhyay, Chief Embryologist, Institute of Reproductive Medicine. They are our physician collaborators. And last but not the least, I wish to thank all my lab mates of Cytogenetics and Genomics Research Unit, Department of Zoology, University of Calcutta, for their continuous support and motivation. Thank you.
Excellent presentation. Okay, so it is basically the male infertility you said in your slide, one slide, it is unexplained infertility. It is not unexplained, it is already explained. It is the male factor infertility. And then we are sampling, when we are checking, it's they are oligozoospermia or azoospermia, then they are undergoing this investigation. Okay, very good, excellent work. I think my co-chairperson, Sonu Shaw. Sonu, are you here?
Yes, ma'am. Yeah.
Yeah, if you want to, it is a kind of a it is not a clinical topic. So if you want to add few words.
Yeah, it was very nicely organized, and he has done a lot of work, hard work. So it was very nice. Yeah.
Yeah, because we know that Y chromosome deletion, type of deletion, and we check it for this, but it is also very new to me to know that this kind of polymorphism can also cause the azoospermia or oligozoospermia, which is very common nowadays.
Yes, ma'am.
Okay. So Sonu, introduce the next one, please. Next speaker.
Yeah. Hello, everyone. Yeah. Welcome to today's session. The topic for this session is there a relationship between blastocyst expansion score and clinical pregnancy? And this topic is going to be presented by Ramya SK. Can we have the CV, please? Yeah. She is currently working as junior embryologist in ARC International Fertility and Research Center, Pondicherry from 2021. She has pursued her master's in reproductive biotechnologies in Università degli Studi Teramo from Italy. She had done training in ICSI in Alma Res Fertility Center, Rome. She has been a research assistant in University degli Studi di Teramo in the field of IVF from October 2019 to 2020. We would love to hear from you. So all the stage is all yours. Please carry on.
Thank you so much for the intro, sir. Let me share my screen. Is the screen visible?
Yes.
Yeah.
Okay. Good afternoon, one and all. Here I am going to present about a topic. Is there any relation between blastocyst score and clinical pregnancy? So, to achieve a successful pregnancy in IVF, a good embryo quality is essential. Either it can be a fresh or a frozen transfer. So, extended culture and blastocyst transfer has been a popular approach in this field of reproduction. Compared with the cleavage embryo, blastocyst culture as a tool for the selecting embryo improved the clinical pregnancy outcome. So, the manual assessment of the morphology of blastocyst remains the golden standard. Studies suggest that blastocyst expansion has a significant role in clinical pregnancy and in live birth. Some of the literature survey. Blastocyst expansion degree may be essential for the successful pregnancy, and blastocysts in early developmental stage and with low blastocyst degree expansion have high survival rate, implantation rate, and live birth. In single blastocyst transfer has found that the blastocyst expansion degree than inner cell mass and trophectoderm significantly affected the pregnancy outcome. But these are the positive papers which said about the blastocyst expansion. But there are some contradicting papers which says that blastocyst expansion may not be more important than inner cell mass and trophectoderm, and it cannot play and it does not play a major role in the clinical pregnancy or live birth. These are some contradicting papers, and also there are some different papers talking about inner cell mass, trophectoderm, and blastocyst expansion to prove one is best over the other. Till date, this debate is going. Which one of the morphology is most important? So, my aim of the study is to find is there any correlation between the expansion score and the pregnancy and the clinical pregnancy transferred in the frozen cycles of embryo. The method we have used is, this is a retrospective analysis. In our center, in our multi-center, we have taken an autologous cycle, which the total patients of 2,352 aged between 21 and 35. This data period was taken from January 2019 to December 2020. Several grading system and classification have been proposed to evaluate blastocysts. But the grading system given by the David Gardner and Schoolcraft still remain unchallenged. So in our method also, we have used the same grading system given by David Gardner and Schoolcraft. Here, this all 2,352 patients have undergone frozen embryo transfer and their clinical pregnancy were assessed. So here blastocysts we scored from 1 to 6 depending on their expansion, and group A represents the score 1, 2, 3, which is an expanding blastocyst, while group B includes the score 4 and 5, which is expanded. We didn't take score 6 because the data is very small, so we have excluded in our study. And also we have excluded in the freeze stage if it is an expanding blastocyst. After post-thaw, if it has expanded and become the expanded blastocyst, that type of transfer is also we have neglected in order to give the precise result about expanding and expanded blastocyst. Here, the clinical pregnancy we have analyzed by the statistical method 2 proportion. So here we can see the result. In group A, we had the patient of 546 and it has given the clinical pregnancy of 181, which is the percentage of 33. And group B, we can see 1806 transfers and the clinical pregnancy is 662 and the percentage is 37. Here we can see in the percentage itself, we can see there is no much difference there we can see there is no difference between each other. And the p-value also indicates that 0.1336, which means there is no significant difference between group A, which is expanding blastocyst, and group B, which is expanded blastocyst. And here we have taken only clinical pregnancy because live birth can be affected by many reasons. But in the present study, we have taken clinical pregnancy because it is straightly associated with the blastocyst quality. Here we can, as per the before slide, group A and group B, there is no significant difference. So the viability of the expanding blastocyst is similar to the viability of the expanded blastocyst. So I conclude here my topic by saying early blastulation and expansion is better with an implantation potential, and a study possibly states that any embryo like grade 1, 2, 3, 4, 5 all has the viability to make a good clinical pregnancy. So finally, I would like to thank my MD sir and ma'am, Dr. Saravanan Lakshmanan and Dr. Mahalakshmi Saravanan, and my gratitude towards our lab director, Sarguna Devi Shivanandam. She not only supported in my work, but also to carry some research work too. And a special mention to statistician Evangeline for collecting the data and analyzing it precisely. And thank you all for your attention, and thank you Ace for making me the tiny part of your event. Thank you so much.
Yeah. Thank you, Ramya. It was a very elaborate study, and you have nicely emphasized on the scoring system.
Yes.
We can take any questions if there are any from our attendees.
Yes, sir. Most welcome to answer the questions.
Himanshu, do we have any question?
No, ma'am.
Okay, so Sonu, you are an embryologist, so can you, do you want to add something? Your
Yes,
experience.
The similar thing is there. The pregnancy rate is more or less similar. It is not more significant. There is no significant difference actually. Early blastocyst also gives a better pregnancy compared to expanded. So there are contradictions also, but yeah, we have not found much difference. We have got pregnancy.
Okay, so I think we are going to close the session then, and this was the last session today, and we are going, the ACE conference today is finishing, so it's the last session of this last day of the conference. So yes. I'd like to thank you all. I'd like to thank the organizer as well, and all the participants. A great event, and we loved all the topics. Selection was very good. This session speakers, very young budding speakers, they all worked hard. My congratulations to all of you, and I'd like to conclude the session here. Thank you very much.
Thank you so much, ma'am.
Thank you,
sir.
Thank you, sir.
Thank you. Thank you.
Chairpersons for conducting the last session of ACE. This marks the end of our session and the conference in Hall B. I would also like to thank the organizing committee for having an excellent lineup of sessions all of the last 3 days, as well as the technical team, the back-end team, and all of the other members involved in making this a success. Thank you all.
Thank you.
Thank you.
जी हिमांशु जी, कुछ होना है और? हिमांशु?
हेलो हेलो
जी
हाँ एंड कर दो।
लंच कर रहे थे क्या आप?
अरे नहीं, मैं बाहर गया था यार।
ठीक है
ठीक है थैंक यू ब्रो।
ओके।